buildings and online. So anybody in the public gallery can do as they normally can, except take pictures and photo recordings of the meeting. Apologies, have we got any apologies? None? Okay. And with Danny joining us online. Okay, moving on then, Chair's business. So just to alert members, I had a meeting with Cathy Harrison the other day discussing neighbourhood model and getting an update on that issue, which I felt was pretty informative. Obviously, we're coming to the point where information is going to become public in terms of the rollout of this. But she did, and I suggested it might be useful to have an informal committee meeting with the rest of us, just if people wanted to get updated in relation to that, so we can organise that. It's better done in an informal way. If people are happy, Keith, you can organise that.
Chair, is there going to be a more formal announcement of what's going to what the neighbourhood model means?
I would imagine. I mean, the meeting, from my point of view, wasn't very informative in terms of who all is going to be on the board and the detail of it and the rollout of it and the numbers of it. So I think if members get that along with the time frame for all those announcements, I think that would be useful to everybody.
Thank you.
Just say, Chair, the Perm Sec did offer to come back to brief the committee in neighbourhood model once there was going to be announcements on it, so we have that tentatively in the forward work programme waiting for dates.
Okay, so we'll take up that offer. Second thing I just want to mention, because I've had a number of two contacts today and a couple yesterday and the day before from community pharmacy, and I know myself and Danny attended the APG on community pharmacy, and that they raised the issue of the supply of medicines, and I know there was some media on it last week. But it's an issue of concern that we all share with community pharmacies in relation to the supply of medicines. Cocodamol seems to be a particular issue, but it's not just that. Some of the pharmacists I've been talking to are talking about unable to get medicines that they need for liver treatment for their patients. So there's a number of medicines that they're struggling to get. According to them, the issue is the prices that we offer here in the north, and manufacturers and suppliers are literally just going elsewhere because they're not getting the price, and in some cases pharmacies are purchasing and dispensing medicine at a loss. So I mean, I know everybody's aware of it. Why I'm raising it is because it's something that I think is increasing concern and will be of increasing concern to our constituents, but also because we have CPNA coming I think in 2 weeks' time to give a briefing. So what I'm suggesting, rather than them coming and raising these issues and then us writing to the department in relation to it, I think that it would be good to get some assessment from the department in advance of that meeting so that we can interrogate their information with CPNA when they're up, because it seems to be an issue that's going to get worse rather than better, and I think the committee needs to be over the top of it. So I would suggest we write to the pharmacy or write to the department expressing our concern about the issue that has been raised by local pharmacists about the supply of medicine, and get an assessment from the department in advance of the meeting with CPNA so that we have all the information when they come forward, if everybody's happy with that. Okay. Draft minutes then. Can I refer members to the draft minutes?
Sorry, just when you're talking about people, when is the minister coming to the committee?
26th of March.
Right. So we had asked as a committee for the minister to write to us upon the outcome of the CAS review of gender services. I don't think that we have got a reply, or if there's a reply, I have missed it. I'm not sure. But actually, the minister published the review on Tuesday evening, and the review is somewhat concerning in that it gives support to young people from Northern Ireland being included as part of the King's College research programme, where those young people would be given puberty blockers. And that is very, very concerning. And I do think that given that the Minister hasn't responded but has published the review, that we should be writing to the Minister again. Personally, I will be writing on behalf of the party to express my strong opposition to young people under the age of 16 being given puberty blockers as part of a research programme. But we should ask what is the Minister's view? Is he supportive of this? And will he be supporting all the recommendations, really?
Okay.
Thank
Linda?
you.
I don't have the same concerns as Diane, so I don't agree with this writing as a committee, but I mean, perfectly entitled to write as an individual. I think that these young people will be doing this in conjunction with their parents' permission. I was listening on the radio the other morning, and that's actually what they were or the other afternoon, and they were very clear that there would need to be parental permission, as there is in any case with research being carried out in relation to children under 16. So I think this is an issue for the parents, the young people and the clinicians to look at, and not really for us to interfere with. But I mean, I'm open to alternative views on that. I just don't personally.
See, Danny's on again. Just for people's information, because the clerk has reminded me that we actually have a briefing on gender services in the next couple of weeks. I think it's the 5th of March. So that's, I mean, we'll have an opportunity to raise all of this then, because obviously there probably will be a variance of views. Danny?
Yes, Chair. I was just going to ask about that briefing, but you've already done. Thank you.
Yeah. So, I mean, I know there's been a couple of things said.
Just to add, sorry to interrupt, just to
Right, go
add,
ahead.
I mean, we did write as a committee. I'm not asking for anybody's personal view on this. I've given my view. So I'm not asking or interfering with anybody else's personal view. We're asking for the Minister's view, not anybody round the table here.
Okay.
So in writing to the Minister, we're asking for his view, not the committee's view. And I accept that there will be a range of views in relation to it. And I don't think that that's an unreasonable thing to ask for.
Yeah, I as I say, we have the meeting on the 5th of March. I mean, we will, I think if we let the department know that at that meeting we'll be looking and updating what the Minister's views are. I mean, because that's what the conversation is going to be about, gender services. So I would expect the department to be coming with the Minister's views. But I mean, I'm easy either way.
If we can make it clear that we do want a definitive view.
Okay.
It's not, I mean, we'll all have a view here, that's okay. But it's the Minister that will implement this review, not us.
I mean, I'm happy one way or the other. As I say, what I was trying to say there probably very clumsily is we will be asking what the department, the Minister's view on all of this is at the meeting on the 5th of March. So, I mean, I'm not opposed to writing in advance of that, but I mean, the 5th of March allows us the opportunity to ask the question that you're asking. Linda?
I'm content that the letter goes as long as it's clear, literally asks for the Minister's view and doesn't give any preamble or anything. I mean, I don't have any issue. I think that Diane is right. There's no problem with knowing what the Minister's position on it is, as long as we're very clear. That
So if we write and say we have this briefing on the 5th of March and we'd like to know in terms of the Minister's view and what direction the department are going in the way forward in advance of that meeting. Everybody happy with that?
Thank you.
Yeah.
Okay, so draft minutes of the meeting held on 5th of February are page 6. Everybody content?
Yeah.
Matters arising? Nothing? Okay, so moving on, item 5, Adult Protection Bill. So the Interim Adult Protection Board, SPPG, within the department are here to give us a briefing. So can I refer members to papers at page 14 of the main pack and page 3 and 7 of table papers? And can I... Hello, can I welcome Dr. Ciara McKillop, Interim Director within Community Care at the SPPG, and Mr. David Pettigrew, Co-Director Community Care within the SPPG, both within the Department of Health. So you're both very welcome.
Thank you. Thank you.
And going to just hand over to yourselves for some opening remarks and then we'll take questions.
Thank you, Chair. And Chair and committee members, I want to thank you for the opportunity to attend today. As Chair mentioned, my name is Ciara McKillop and I'm the Director of Community Care in SPPG, and I am accompanied today by David Pettigrew. David is my colleague and co-director with responsibility for adult safeguarding. And we want to provide the committee today with an update on the work of the Interim Adult Protection Board, the IAPB. We've provided members with a briefing paper in advance which sets out the background to the IAPB and some of the work it has taken forward since its establishment in 2021. So I will keep this introduction brief. Included in the briefing paper is some learning from the IAPB to date, which we think will be helpful in informing the work of the new Permanent Independent Adult Protection Board when it's established under the new legislation. The IAPB has been in place since 2021, and part of my role as Director in SPPG has been to chair the IAPB. I've had this role since 2023, taking over from Brendan Whittle, who was my predecessor. I am also a board member of the Safeguarding Board for Northern Ireland, and SBNI focuses on safeguarding and promoting the welfare of children and young people in Northern Ireland by coordinating the work of all of the agencies involved in the child protection system. SBNI was established in 2012 and is very well established with a 10-year head start on us. And whilst their focus is on children and families, there is very relevant learning for our adult-focused board. As noted in the briefing report, the IAPB was designed as a temporary structure. It was a proof of concept or a precursor to a permanent independent board. And the IAPB has had an initial statutory focus with a membership across statutory agencies who have a role in adult protection, and we meet bi-monthly. Following the enactment of the bill, the IAPB will be replaced by a new and fully independent board established on a statutory footing, and we recognise the need for that board to be and to be seen to be fully independent. The IAPB has, however, enabled the development and testing of key adult safeguarding and protection components, and it has taken forward preparatory work in anticipation of the new permanent board. So, for example, we have completed work around future training needs, we've revised the joint protocol arrangements between health service staff and the police, we've improved the regional data set, and we have developed a preliminary model for serious case reviews. It is our intention that we get the new permanent board off to as strong a start as possible. Like SBNI, we have adopted a model of identifying and prioritising key areas of work and to creating subgroups focused on specific areas to progress these, namely a data and performance working group, one on training and development, one on how we engage user involvement, the implementation and development of statutory guidance, and the revision of the joint protocol process. Some important learning for IAPB has been the challenge in securing user and carer input into the board and subgroups. The Patient Client Council are members of the IAPB and they greatly assist us in this work. They host a user engagement platform for us, but I think it's fair to say that whilst a number of approaches have been tried, input can be variable, and this is an area that we are still working very hard on. We remain fully committed to co-production, to involving people with lived experience and broader stakeholder participation, and we consider that this is absolutely essential for the independent board going forward. In terms of data and performance, to better understand adult protection activity, manage the service and drive service improvement, a new regional dashboard is in development linked with Encompass. Key metrics have been agreed, and we had a demonstration of the dashboard at our last IAPB. So the next phase of work is to confirm standard data definitions and build that guidance into the training for staff. And this will in time allow a real-time understanding of adult protection work across the region, allowing us to understand regional variations and trends. The committee will understand from the contributions of other interested parties that the effectiveness of adult safeguarding protection often hinges on the knowledge, training and support of the workforce from whatever sector. The IAPB's subgroup on training and development is working very closely with the Department's Office of Social Services on the development of training pathways. Training will be delivered at different levels to individual staff depending on their role and their contact with service users. So, for example, awareness training will be largely available. This work has, of course, included the community and voluntary and independent sectors who are engaged in the work of the training subgroup and will contribute to identifying and taking forward training within their own sectors. At the other end of the spectrum, the highest level of training will be for adult protection social workers, and this will focus on the powers and duties that they will have following the introduction of the bill. As we have progressed the work of the IAPB, we have listened to people who have lived experience, people who access our services, and families involved in the various IAPB subgroups, and we have learned from their experiences. One of our colleagues recently met with Professor Jill Manthorpe, Professor at King's College London, and a visiting Professor at Queen's to help us focus in on how we can improve our engagement, develop a hub, use focus groups more effectively, and be better able to engage interested parties. We recognise that we have much work to do. Similarly, whilst the IAPB was originally mandated to focus solely on statutory protection work, as we have moved through our original work plan and statutory focus, we are now broadening our focus to include adult safeguarding and prevention issues, and our next phase of work is to be more closely engaged with the local adult safeguarding partnership groups, the LASPs, and to bring safeguarding and prevention into the heart of the IAPB, and this is something that the new board will want to consider too. The SPPG Adult Safeguarding Lead already regularly meets with LASP's chairs, attends LASP meetings, and in future LASPs will attend the AIPB to inform us about their local priorities and their local work plans, and for the regional board to consider how we can support local work and have a much more effective two-way communication. Finally, as outlined in the briefing paper, the future chair and staffing structure of the permanent board will require careful consideration to ensure full independence and that it has sufficient capacity to carry out its functions effectively. In exploring potential models, as I mentioned earlier, the IAPB has examined the Safeguarding Board for Northern Ireland, which provides independent oversight of child protection, and we have identified several practices that could be beneficial for the new independent board. And in addition to those mentioned already, I would include the use of an online platform for updated policies and procedures, a 5-year strategic planning cycle, a focus on emerging thematic priorities, and the delivery of annual learning events to embed learning in practice. And there is, of course, the potential for future collaboration and shared events between the Independent Adult Board and the SBNA on areas of shared interest. Thank you.
Okay, thank you very much for that. That's been useful. And you talked about fully independent a couple of times in relation to the board. And in your submission, you're setting out that the permanent board will be independently chaired and operated at arm's length from the DFH. Some of the stakeholders and some of the evidence that we have taken suggested that might not be sufficiently independent to ensure accountability and change. So I'm kind of just trying to gauge your position in that, and the other question I was going to ask you is how is the proposed board going to differ from the interim board? So if you could potentially ask both those questions, just in terms of the concerns that some, not all, but some have raised about the fully independence of the board and just the difference between what's currently there and what will be when it becomes fully formatted.
And I suppose it's a challenge that we've wrestled with ourselves, because how do you have somebody who has the sufficient expertise and knowledge and gravitas to be able to complete the work of the Adult Protection Board the way that you want it to happen, but somebody who hasn't been involved in the development of those services, or that hasn't been their career as we've gone along. When we look at SBNA, their model, they have an independent chair. They have a chief operating officer who would be from historically two different statutory agencies, and then they have lay members on the board which offer them a level of independence, and that's possibly something that the adult board would consider.
Okay, but I think the not criticism, but the suggestion was that whoever, they needed to have no ties with the Department of Health, whether you have independent commissioners from the South or Britain or somewhere else. I think that was the kind of suggested model that they were suggesting.
I suppose it reflects very much the discussion that when PCC were here and they talked about how challenging it is to achieve truly independent advocacy, because when you track it back, somebody's paying for it and somebody's in charge of resourcing it. So I would argue that if you're employed to be an independent chair of an adult protection board, that you're employed to be independent and adult, and part of your role is to be a critical friend and to use that responsibility very thoroughly, and not a straightforward one to answer.
Okay. The other thing that you talked about, picked up on, was in terms of the importance of the training. Obviously, whenever this legislation comes on, and it's a question I'll be asking the department next, but I just want to ask yourself, because I mean, the suggestion is that there's a resource of 8 million required for training. Knowing some of the concerns that probably all the committee would share is that we get a great piece of legislation, but we don't actually have the resources to implement it. And I know the suggestion is that we implement it over a phased approach, but obviously the training of the staff is vital at the outset, regardless of how you phase it. So, I mean, have you any concerns in relation to that?
You want to?
Well, I've a couple of issues I suppose I would flag up. The first thing to say is that there is training at the moment ongoing on, so we're not starting from a level playing field. But I think you're referring to training specifically in terms of the new bill. Yeah. But just in terms of the backdrop, there's different phases or different staged training at the moment in terms of like early awareness or general awareness up to those specialist roles in terms of joint protocol. So there's a 3 to 4 stage specialist training. In the new model, or the model that's been worked up in terms of the new bill, I think the stages go up to about stage 7, and the higher, most expert level would be the adult protection social worker, who have the responsibility for using some of the powers and authority within the bill. I think one of the big asks, I think there's going to be 2 big asks. One is about the resources in terms of human resources, staff on the ground that are knowledgeable and available to deliver the service, but also the impact of migration from different parts of the service to what may be, what I'd said anyway, is a new and exciting area to move into. So how do we keep the workforce and the skill base stable over that period? I think investment's important. It's important in terms of making sure that it's role specific, and that the people who are doing these carrying out these very specific roles are skilled and they're competent, and that's important right across the piece. You mentioned the phased approach. You're absolutely right. This bill, I think, will have to be phased. One, because of the resource, but also because I think the system probably isn't ready for a day one big bang, and I think that's true of other pieces of legislation as well. I think training is the starting point, but it would probably build on training that we already have in place at the moment anyway.
Okay. Yeah.
I just wanted your view on an issue that has cropped up in relation to the board as will be established. And that was that there was some suggestion from some who gave evidence that if the makeup of the board isn't right, then it could be seen as, I suppose, like both poacher and gamekeeper at the same time. Do you see that as a real issue? Because of the nature of the people that are probably going to be part of the board, because we in Northern Ireland, and I suppose it's I can understand why it happens. We kind of have the same people who appear on boards all the time, and the concern was expressed about the true independence of the board. And I think in this case it's really, really important, because this bill transfers powers to the state over intervention in people's lives that are quite significant. And therefore having a rationale for a truly independent board that's looking what's happening is also really, really important and significant in my view. Maybe others have a different view.
And I don't
want to put you on the spot, but I just think it's something that, when it's mentioned, concerns me, because it's such such extensive powers in this bill.
There are, and I think they are needed, and I think that the bill in its entirety is welcomed, because it does address, I think, some of the deficits that have occurred in the past. And to answer you, I suppose I would draw on my experience of SBNI, where they do play that role of poacher and gamekeeper, because they do focus on improving practice and understanding some of the new child protection concerns that have come up. You know, they do look at areas like online harm and child criminal exploitation, child sexual exploitation. So they do focus on the development of practice and understanding and addressing some of those harms. But at the same time, they do hold agencies to account for current practice and for things that they have done, and they are able to do that. They are able to do both of those things. You know, they are able to improve practice, but they're also able to address practice, and they do
You've
that.
just
yeah.
sort of gone on to the second
sorry.
half of my question, which is really the issue of accountability,
Mm-hmm.
which when we had the Muckamore families in here, nobody's accountable. You know, see no evil, hear no evil, do no evil, sort of, you know, and I'm saying this is the view they expressed. And given what they've been through, it's a legitimate way to understand the system that their loved ones have been through. And some concern expressed about others still going through a similar system. So how is accountability managed in this situation, and who monitors the board for the way they hold people accountable?
Who monitors SBNI?
Yeah.
Well, I mean, SBNI is accountable again to the Department of Health, do you know, and to the Office of Social Services, and they do look at their annual report. They do look at the model of case management reviews that are in place. They do periodically review that and audit against it, and I mean, I've attended meetings where the Chief Social Work Officer has brought the SBNI staff to receive assurances that learning is being implemented, that their check-in learning is being implemented, that RQAA is being used to ensure that learning is being implemented. So it's the question of, I mean, there's accountability at all different levels, as you'll know, from the level of the individual practitioner to how they are managed within a team, to how any service is provided, to, you know, how we in SPPG hold the trusts to account through the use of statutory functions reporting, and also through the statutory outcome measures and the our intervention framework, where we do receive performance management information from the trusts. We do take account of variations and trends. We do match that with financial information, with information from serious adverse incidents, from complaints, and we do put all of that information to sense check whether a service is healthy and effective and functioning or not. We meet with RQAA and with NISC so that we can have as holistic a picture of a service as possible. But I did take the opportunity to watch back the feedback from the Muckamore families, and it is very powerful.
And it's very concerning.
Very concerning, and
Yes,
it is
it
a
is.
real, it does make us stop on our tracks to stress test everything that we're doing, and to think critically about what we're doing and how we're doing it, and if we are missing things. And I do go back to the centre of this, which has been a challenge for us, and is making sure that people who are being cared for and their families are completely central and listened to and heard, because I think that some of those families have just lost their trust in the system, and the challenge for us is how we are ever able to get that back.
Can I say, please? Yeah, I think it was very, very powerful, the message from that session. But what it reinforced for me, and maybe for others as well, was the importance at that individual level. So the trusts have their governance structures and how things work in a hierarchical way. But the really important thing is that you have well-trained, well-supported, well-supervised staff at operational level, and the management structures from there upwards are actually in place and are being supervised and frankly being scrutinised as well. Because a lot of those difficulties that start to develop, they develop at that patient or client to individual interface. And I think if that is right, then we don't get to SAIs, we don't get to inquiries. If you deal at a very operational level where people are supported in their posts and really doing their jobs well, I think we can probably avoid some of the very unhappy stories we've had in Northern Ireland.
And if care plans are well thought out and well resourced, and, you know, people's behaviour is well understood for what it is trying to communicate, and their needs are met effectively, if we get that bit right, the rest will flow.
Thank you. I do appreciate that everyone involved with this is trying to get to a situation where we are satisfied that we have a system that operates well, but that is also accountable. But I just think that in light of the conversation with those families, I'm not sure that we have done enough to gain their trust in that, and that's not your fault. It's just, you know, I'm just expressing a view of what they said, and I do think it is a really serious point that we need to think about. The accountability for very stringent measures in the bill should be really, really rigorous. Thanks, Chair.
Just before I bring Danny in, I mean, I think it's very right that Dan has highlighted the evidence we heard from Mucklemore, because ultimately this bill, I mean, if not that we gain their trust, the very least it must be is ensuring that we don't have a situation like Mucklemore again. And so all of this is the reason why we're having this conversation. Mm-hmm. So, I mean, we just need to be confident in all of this piece of legislation, whether it's the board and everything that flows from it, that we have such strong legislation in place that we don't ever have a repeat of what happened in Mucklemore. And I mean, the training and all is really good, and that hopefully that ensures that staff and everybody is focused on the work that they're doing. But if somebody does step outside the line, that it's identified early and resolved early. I mean, I think that, I mean, that has to be, we as a committee need to be satisfied that that is the case. Danny?
Thank you, Chair, and I absolutely agree with that. And I think it's worth noting as well that the final inquiry report is due in March, I understand. So that'll be the context that, you know, we'll be working in as well. I was very struck by what Ciara said there about people who are being cared for and their families being the centre of this, and that some have lost faith. I think that's very striking and sad. But it is where we are. Could I ask just a couple of questions? The first one, just about the regional dashboard that was mentioned. Ciara, just so that you have a real-time understanding of adult safeguarding, what metrics feature on that?
So, you have to drag my memory banks now. So it begins with the reason for referral, the demographics of the person who's been referred, who received the referral,
the outcome of the referrals. The dashboard's been revised a bit recently, and it started as a very basic dashboard, which was really number of referrals, and then you would have mapped that over the different places in Northern Ireland. It's become more sophisticated. This work has been ongoing the last couple of months around that. So the domains would be about the referral source, the trust area. So then you can mark that in terms of the outcome of the referral, whether it was actually signposted to a safeguarding, which is a more supportive approach, or an adult protection approach. And if it did go down that route, how many actually ultimately then led to care planning and case conference outcomes as well. So it's work in progress, but ultimately in terms of oversight and standardisation across Northern Ireland, I know the committee's been very interested in that. Good quality data, I mean, we've mentioned training, but I also think really good quality data will give the current interim board, but also the permanent board, regional oversight, look for bottlenecks, look for unexpected high points in terms of referrals, but more particularly in terms of what I would think of as conversion rates, where maybe a trust area would have a very high referral rate, but a very, very small number of cases that might proceed beyond that, and try to understand why that would be. And there are reasons why that would be, but it's just by trying to get to the root of that.
Thank you. Actually, the standardisation was the next point I was coming along to. Just something we found out time and time again is the difference between trusts and how they operate in this committee. What was your experience of working across trust boundaries?
I suppose we had quite a detailed debate the last time, because the number of self-referrals I felt too high to the experienced practitioners who were around the table. So we're at the stage now of working to agree data definitions so that we can record completely who is making referrals, because when we have a standard agreed set of regional definitions, then we will properly be able to look at regional variations and understand them. Because at the minute we were a bit concerned that, for example, Danny, if you were working in ED and somebody disclosed something to you and you filled the APP one in, we just need to make sure that all hospitals record that either that's a self-referral or a referral from a nurse, that it's being done consistently. So we've still just a bit of work to finalise that set of data definitions and then make sure they're built into Encompass so that everybody is recording the same thing, and then we will have a proper data set that we can use to standardise and to understand that. So it's not far away, to be fair. We've got the metrics, we've got the we're confirming the metrics, and then they're going into the training
Just to say
platform
something.
to put them out. Sorry, David.
Sorry, okay. I was going to say about the data. I mean, the data is a double-edged sword in a way, because when you look across the piece, you will naturally see trusts, or actually teams within trusts, that have peaks and troughs. So then you might look and you might say, well, actually, you know, living in Trust A must be quite dangerous because the referral rate's really high in that trust, whereas really low in Trust A. But in fact, the converse might be true. You might have a really good system operating in Trust A gateway team, lots of referrals that are screened in, you know, sifted through, and that actually could be a safer service. So at times when people have requested data and jumped on that, which said, you know, clearly Trust X is very, you know, very unsafe place to, it might actually be quite safe because you've a service that's alert, and you have a service that's actually proactively doing things about safeguarding. So, I mean, the data has to be seen. That's why I mentioned the conversion rate's important. Yeah. You might have a very high referral rate, but actually when those are interrogated, actually the number that proceed could be quite low.
And I suppose just to say, do you know, one of the issues that was raised by Glenn Brown, Mr. Brown, when he was here, was the family's frustration that the procedures that are in place are being implemented differently, and different forms are being used. And I mean that we are working to address that and to understand and to address regional variation, because we know that perceived inconsistency is a real big sense of frustration for the families.
Absolutely, and that was very clear in the evidence that we got. And what we want to see is a uniform regional approach, but obviously that should be grounded in best practice as well. Absolutely. So we get the best practice right across. And thank you very much for that. Just one other question. What lessons have you learned? And obviously you've been, the Interim has been going since 2021. What lessons have been learned to inform the provisions of the board in the bill? Any particular big lessons that jumped out?
No, I mean, I think we've done quite a bit of work around the area of serious case reviews, and our proposal suggestion is that they're not called serious case reviews, that they're called adult protection learning reviews, because the police already have serious case reviews within the PSNI, and we have case management reviews, domestic homicide reviews. So we spent quite a bit of time making sure that they all work together, that they don't get in each other's way, that they're pieces of a learning jigsaw. So that we've spent quite a bit of time looking at that, and I suppose our next phase of work is going to be when the bill is confirmed, the whole area around the development of the guidance, which is probably as important as the bill, because it's how it'll be translated from a piece of legislation into operation. So don't know if that answers your question, Danny. I mean, the other learning we've sort of talked about, the centrality of people being involved. We're very, very much in agreement with the principles that are outlined in the bill, fully supportive of that.
When I think back over, just to answer your question, I mean, when I think back over the last couple of years, and if I was asked, you know, what do you think are the wins, or what are the things that you're starting to win, I think data is starting to come into the frame now. I think that's an important one. You mentioned the serious case reviews, the adult learning reviews. We have that framework worked up, and when the new permanent board comes in, they should be able to lift that and run with it. And we were assisted by colleagues in Queen's University to do that. So it's a good piece of work, and it's in draft, but it can be taken forward. The regional and joint protocol arrangements have been entirely reworked and redrafted. They were approved at our board last couple of weeks anyway. They were approved recently, so we have a brand new joint protocol document signed off regionally, and that is absolutely ready to go as well. So I think that's been good. The other element, I suppose, is sometimes you learn by things that don't actually work as well, and some of the user engagement pieces we started with just didn't work particularly well. It's very hard to get consistent, meaningful engagement with users and carers. So we tried a couple of different models and a couple of faltering starts, and it's still work in progress. So there's been a few wins and a few things that we would take forward and we'd share with the new permanent board. And the first thing is, if you're talking about meaningful user and stakeholder engagement, start early and repeat and repeat and repeat. That would be my experience of the last couple of years.
That's very useful. That's great. Thank you very much. Thank you, Chair.
Alan?
Thanks, Chair. I just reading through the paper last night, and I was looking at your opening page in the submission, and you made reference quite rightly to the original review and what followed, home truths, and how family voices were repeatedly unheard, I think was the term that you used. And it did strike me, as stupid as I am to this process, of how little there were in terms of family voices or family advocacy groups, you know, in the original interim board. And even within the subgroups, there don't appear to be any family voices, as the review had encouraged. But I note that in part of your submission as well, you say that some of the challenges that you're facing in terms of user involvement. What are those challenges?
Well, I suppose to go back, the original remit of the board was for it to, the IAPB was for it to be a sort of 18-month project to work solely within the statutory agencies. And obviously that's 3 years ago. So since then we now do, I think joint protocol's the only group that we don't have a family or service user involvement in. They're in
we
the
have
other
users
four.
and families in the subgroups.
And we do have the PCC host a user engagement forum for us, so that when we have something that we want to share with families, ask them their views on, consider, give us their advice on. That's how we're doing it at the minute, through the PCC and through the user engagement platform. I think our challenge, Alan, is we think we could do more, better, different, and we are looking at things. I mean, certainly there's a suggestion that we would use focus groups more effectively. We would perhaps, you know, maybe buy in groups who could go out and canvas views for us from interested parties, which are things we haven't done to date.
That's right.
We would like to get to the stage where we do have the community and voluntary sector and service users on the Interim Adult Protection Board, because we haven't done that to date, because we have been focused on statutory agencies. So we sort of know where we would like to get to over the next year, but it has proved a challenge for us to have people who will respond to things that we're asking them. Do you know, there are sometimes PCC have tried and, you know, nobody has responded to a question that we have asked. So we just think we can do this better and differently. And we have brought Jill Manthorpe in just to say, how is this working in other places? How have other, you know, adult protection boards or other boards harvested the views of, got the engagement of, had people involved and interested in the work that they're taking forward. So she's certainly given us a few ideas which we discussed at the board, and we have. It mirrors sort of that mixed methods approach, because that's what SBNI do. They do focus groups, they have people on the board, and they do, you know, they would just employ groups to go out and canvass the views of children or canvass the views of parents about things that they're proposing to do. So that's, I think, what we are going to have to do, and I think it's what the permanent board will have to do in the future.
Just on the issue of trust, because I know it's crept up on here today, and it crept up frequently, the word, whenever we had them more families before us. In terms of transparency, in terms of the board's proceedings, or the interim board's proceedings, how public are those proceedings?
It's a minuted meeting, and the minutes are actually on a public website.
Fair enough. Okay.
We have like a sort of precursor website to, I would imagine it'll just go with the new board, but we do have a precursor website where all that information is available for people to read and see and comment on.
And the dashboard, like Danny touched upon the dashboard, when do you expect that to be fully operational?
I think we got to that.
In the next month or so, it's worked up well. It's just how we're going to host it and how we're going to keep it updated as well, because it's really good today, but it will be really good in 6 months' time. It's the servers and those types of databases are very difficult, so we're trying to work out how to make sure the data is coming in as quick as we want it to come in. So, next month or so.
Okay, thank you very much. Thank you. That's been useful. Appreciate that.
Okay, all right, thank you very much.
Okay, members, item number 6, same thing, Department of Health, and to give us a briefing on the Adult Protection Bill. So can I refer everybody to the papers at page 71 of the main pack. And we'll just await our next So can I welcome Miss Kerry Loveland Morrison, who's the head of Adult Safeguarding Unit within the Department of Health, Mr. Mark McGurkin, Director of Disability and Older People within the department, and Miss Anya Morrison, Chief Social Work Officer within the department. So you are all very welcome. Thank you very much for coming. We obviously have gotten your submission, so I'm going to hand over to yourselves just for some brief opening remarks, and then we'll take questions from members.
I'm sure I'll make some opening remarks and I'll keep them as brief as I possibly can. Always a pleasure to come back to brief the committee on where we are and an update on the draft Adult Protection Bill. You've already noted I'm joined by Kerry Loveland Morrison today, who's the head of the Adult Safeguarding branch within the department, and Kerry's team have been leading on taking the drafting of the bill. Kerry was here with me last June as well, and also Anya Morrison, the Chief Social Worker in the department, who is also the head of the Office of Social Services. Since we last met in June, both the Department and the Transformation Board have considered and approved a range of potential amendments to the bill. This is following engagement between the Department and stakeholders, and also following consideration of issues raised in evidence to the committee. It's important to note that these proposed changes have not yet been endorsed by the Minister, but we will put formal advice to him in the coming weeks in terms of getting his support for the amendments. Opening comments will cover some of the major changes, and we're also happy to address any questions after that. Just to note, a number of the issues have already been covered in the written briefing to the committee, and I'll do my best to keep them as brief as possible. Firstly, in relation to the serious case reviews, we propose to add provision for independent advocates to the bill, along with further detail around serious case reviews, which will set out minimum procedural standards for the reviews, including requirements for independence, timeliness, public scrutiny, and involvement of the next of kin. I suppose it's also important to note that we propose to change the name of serious case reviews to Adult Protection Learning Reviews, as we consider this better reflects the focus on learning from the cases being examined rather than governance and accountability, which is not the purpose of the reviews. There's also been ongoing discussions at the Transformation Board taking account of legal advice in relation to naming of professions under the duty to report and cooperate in Clause 4. As a result, the Department is proposing to amend Clause 4 to reference irrelevant pieces of legislation that cover all medical professions regulated by law in Northern Ireland, as well as social workers and social work practitioners. This is largely to avoid the inclusion of an unwieldy list of professions at Clause 4, which would require ongoing updating to the legislation every time a profession changes. As a result of this change, and again following legal advice, we'd also propose to remove clauses 4.1g and 4.1h, as these are unnecessary with the above proposed changes. The Transformation Board have approved the proposal to remove these clauses. It was also agreed that unregulated professionals would be referenced in the statutory guidance rather than under Clause 4. This is a similar approach to Scotland, with direction that it is best practice for all health and social professionals to report to the trusts, and that would be in the guidance rather than on the bill. Following requests from PCC, we also propose to remove them from membership of the Adult Protection Board at Clause 33C. A range of issues have also been raised at briefings or oral evidence sessions on the bill, and I would like to touch on a few of these today. At our last briefing in June 25, we noted the inclusion of emerging types of harm in the bill. Legal advice has confirmed that any emerging type of harm will be covered by the bill if it involves harmful conduct of any description. In relation to previous discussions around mandating of CCTV in the bill, the Department's position and the Transformation Board position remains unchanged, in that the legal advice received is that it would not be within the legal competence or the legislative competence of the Assembly to make CCTV mandatory within the bill. This is because the inclusion of such requirement would contravene Article 8 of ECHR. Classification was also sought from the Northern Ireland Human Rights Commission following its evidence to the committee on the 6th of November that it was possible to mandate CCTV. The Commission subsequently clarified in writing to the Department that this should not be interpreted as support for a broad legislative provision mandating CCTV in all health and social care settings. The Commission also agreed that with the advice the Department has received, that such a blanket requirement would be unlikely to comply with Article 8 or indeed Windsor Framework Article 2. The Transformation Board has also considered the proposed amendments put forward by the Human Rights Commission to the committee and considered that the Adult Protection Board was already fully compliant with the human rights obligations. The Department also acknowledges concerns that the committee has raised about the pressure to fill new adult protection social worker posts that the bill will create and the fear that result in gaps in existing social work provision. Colleagues within ONU's Directorate have overall responsibility for workforce planning, and this is being considered alongside a training plan. There's been significant work to increase social work places in recent years, training places in recent years. However, continued investment in training places and the ongoing programme of social work reform will be required to ensure that when recruitment for adult protection social workers begins, positions can be backfilled with more experienced social workers into other roles. The Department has also outlined in the briefing supplied to the committee why self-neglect and self-harm should not be specifically referenced within the bill. By way of further background, Scottish legislation refers to responsibilities to provide both early intervention safeguarding to support an adult and protection interventions to intervene in an adult's life. However, the current draft of the bill only refers to protection interventions. There are already existing health and social care trust systems and processes in place that work in partnership with other agencies to support adults exhibiting self-neglect and self-harm. This issue has been discussed at length at the Transformation Board to ensure all parties are in agreement with the wording of the bill, and that is in place from all parties on the Transformation Board. Progress has also been made on the development of the statutory guidance to accompany the bill. The guidance has taken account of a number of the suggestions raised in the oral evidence sessions in relation to what should be included, and we hope to put the guidance to public consultation in the coming months. We will also share the final draft of the guidance with the committee at the same time. In relation to funding to implement the bill, the committee is aware that the Adult Protection Bill business case was approved on the condition that the bill would not be enacted until such times as funds are available. This means that the draft bill will be introduced to the Assembly, but implementation will be delayed until such times as the budget becomes available. As previously outlined to the committee, new powers in the bill cannot be enacted without the recruitment and training of a range of health and social care staff, including social workers, investigation officers, administration staff, etc. Staffing accounts for the vast majority of the costs to implement the bill, and by way of example, in year one, staffing costs are estimated to account for around 7.4 million out of the total 12 million to implement in year one. The Transformation Board will recommend the order in which the implementation of the elements of the bill should be implemented, and that will also take account of available funds alongside policy and other considerations, including any views from the committee. Officials have developed a draft implementation plan, which has been provided to the committee, which identifies which elements are lower cost and could be implemented first, subject to funding. For example, the Adult Protection Board could be established for a relatively small amount compared with other elements. However, this would require the development and approval of related regulations, which is a similar process to the establishment of the Safeguarding Board for Northern Ireland. As I noted, the draft implementation plan has been shared with the committee for information, but it's important to note that it's not ranked at this stage in order for importance or prioritisation. It's simply a reflection of the financial implications of the various elements of the bill. There are several outstanding policy issues still to be resolved, including naming the Northern Ireland Prison Service at Clause 4 in the bill. The Transformation Board has discussed this on a number of occasions, including the meeting in September and most recently the meeting in January 2026. And the Transformation Board has reaffirmed its position that prisons should be included within Clause 4. That is noting that both prisons and justice our colleagues on the board did not agree with this position at the January meeting. Engagement between both departments is continuing, and we hope to get a resolution at official level of this position. In addition, when the British Medical Association and the College of GPs gave evidence to the committee in December, they stated their opposition to the definition of an adult at risk in the bill, which includes adults with capacity to make their own decisions. The committee subsequently wrote to the department about the issues raised, and our response to the committee sets our position out in detail. In summary, the department's position is that the definition of an adult at risk at Clause 2 should apply to adults at risk with and without capacity to consent. This is supported by legal advice underpinning our view that the duty of confidentiality itself is not an absolute duty, which was also acknowledged by both BMA and the Royal College of GPs in their evidence to the committee. Disclosure under the bill would be covered by the required by law exception if the bill as drafted was passed, as the duty to disclose would be a statutory duty or a duty to comply with a court order. In closing, I also want to note, Chair, that the Transformation Board is currently meeting on a monthly basis to ensure effective consideration and decision making in relation to the proposed amendments, queries and other issues related to the bill. and these monthly meetings will continue as the bill moves through the committee stage and into the final stages of the Assembly. And Chair, we're happy to take any questions that the committee has.
Okay, thank you very much for that. That's been useful, and your paper was useful. Just the kind of last issue you talked about was the ongoing conversations with GPs in relation to the consent issue. So I'm just wondering if there's an update in relation to more agreement in relation to that issue.
We've had a number of ongoing conversations with the Royal College and with BMA, and we're actually having further conversations with our professional colleagues within the department, Chair, to make sure that we're all aligned on that. We haven't had any resolution to that position yet, but we are still trying to take that forward. But we believe that it should cover both those with capacity and those without capacity.
Yeah, no, and I understand your position.
Yeah.
It's an important issue, and it would be good to have consensus. That would certainly help the committee in our deliberations. Time frame and all of this is important, and you talked about, and you've sent us an implementation plan, but there's no kind of time frames attached. So I want to ask in relation to that. Obviously there's going to be a phased approach to the implementation of the legislation. Would it be more useful? I'm asking that question because I think it would be more useful if there were time frames. Otherwise, how long is a piece of string in terms of this? So is time frame something that you would consider putting into the bill in terms of implementation? And then on that, but a similar issue in terms of the statutory guidance, I think you said you hope to have that ready for public consultation in the near future. If you could give us a wee bit more of a firmer time frame in that and the length of consultation.
Okay. I'll let Carrie answer that second point. In terms of the first one, in terms of a timetable for implementation, it largely does depend on the funding, Chair. So it would probably be a bit of a false timetable for us to say we could implement it in 3 months, 4 months, 5 months without the funding in place. So when we agree a prioritisation, we will then start to do individual implementation business cases, but we will have to have an implementation plan in place as well. You said we don't want to see this drifting on, indefinitely. So we will look to secure the funding and then implement as we secure the funding. I think the two things go hand in hand, rather than having a plan in place that I say probably sets false deadlines without the funding being in place. Yeah.
Okay, I understand that. Before Kerry comes in, I understand exactly what you're saying, but the other concern, the alternative concern, is that we have a great piece of legislation that goes nowhere because there's no definitive time frame, there's no pressure to get resources to implement it, and the kind of stories that we've heard previously from the likes of the Muckamore families, I'm not saying happen again, but we don't rectify that scenario and situation because we're just letting things drift. And if there's not pressure applied in terms of the department or the minister to find money and resource to implement a vital piece of legislation, then we may see the time frame for the implementation drift.
I can only repeat, Chair, that until we have the money, it's very, very difficult to put a timetable in place. I could reassure the committee that we have already started the bidding as part of the process for next year's budget within the department. We have put bids forward for the money we would need. Now that's new money because that money isn't currently being used. So that's going against everybody else who might have programmes already in place, Chair, but we have already started that bidding process in terms of putting our best foot forward to try and get the money to implement as quickly as we possibly can. But I say that's up against everybody else's priorities as well. We can go away and have a look at an implementation plan, Chair, and try and put some timetables or time scales around it. We could, for example, say if we were looking to implement the Adult Protection Board, how long would that process take in terms of the appointments and that sort of process? So I think that's something we probably could take away, Chair, from today and start to look at if not putting a timetable against some things, how long it would take to implement some things, and then at least we would have some indication of the likely time scale to take some of the bits forward.
I think that would be helpful. I think the more definitive information we have, the better.
Yeah, no problems.
Okay. Kerry, if you want to maybe answer
So about the guidance, we haven't agreed a specific date by which the guidance should be out for consultation. What we've always talked about is that it should be while the bill is going through its latter assembly stages, so that it could take account of any amendments going through. The guidance as drafted at the minute reflects the bill as it is, so it will need to be updated with any amendments that come through. We also have given a commitment to some of our stakeholders that we would hold pre-consultation with them, so that they have a chance to contribute to the guidance's development. But at any rate, we are intending to consult before the springtime.
Fair enough. I have a raft of other questions, but I'm going to allow members to come in because I presume that they might pick up on them, and if they don't, we'll come back to us at the end. Dan?
Yes, thanks, Chair. So, just what do you estimate the total cost if this bill was to be implemented in all areas? What do you think the total cost of that would be? Because I've heard varying estimates of that.
The total cost, Diane, is around 120 million, just shy of 121 million. I think we have provided those figures to the committee previously. So over a 10-year period, that's the business case we have to look at. So over a 10-year period, it's just shy of 121 million.
So you said that you were going to make amendments to the bill to allow for independent advocates. Mm-hmm. Have you costed that?
We have costed in terms of independent advocacy at this stage. The independent advocates are sitting at around 2.6 million over the 10 years. Now, that is for provision for independent advocates at different stages of some of the things going through the court and that. So that's the sort of, that's based on that is based on around 530 investigations a year. General investigations for advocacy will be required, and a number of hours per investigation, and that is largely, we've done a lot of our modelling based on the experience in Scotland. So we've looked at how many cases went through the Scottish courts, and then we've extrapolated that back for the population in Northern Ireland. So that's roughly where we are, about 2.6 million over the 10 years for independent
and is
advocates.
that included in the 121 million?
It is, yeah. Yeah.
Oh gosh, sorry, I was just wondering, because you're making amendments to include for, does that add an additional cost?
If I could add to that, the figures that we've costed for at the moment were for the bill as originally written.
Yes,
and
so
that
there
didn't
would be
build
an
them
additional
into,
cost
yes,
in that.
That didn't build them into serious case reviews, which, as Mark said, that's one of the that's one of the changes that we want to
in
make.
In terms of independent advocates, at what level have you pitched that? One, so they're truly independent, and two, that they have the expertise that is needed in order to represent people properly, say for example at a SAI.
I'm not sure exactly what level we have pitched it at. To answer your question, we have pitched it at an hourly rate, which is the hourly rate I'm assuming we've used for other independent advocacy. In terms of your making them truly independent, this is something which has been raised by some of our PCC discussions and around that. So they have to be employed by somebody. So for the purposes of this, they would probably be employed via the trusts, because we need an employing body to employ the independent advocates. So whilst they would be independent, they need to be employed by somebody. In the same way at the minute, independent advocacy for the likes of some of the patients still within Muckamore, they're employed through a contract with the trust, but it would be by a third party who actually supply them. So I would envisage it being that sort of arrangement.
So
where
that would be something like if it was a child, the Children's Law Centre,
or something like that,
or something similar.
Yes.
Who would provide those, but via contract
with the trust. Yes. Mm-hmm.
So that they're not trust employees. That's what I'm trying to get to.
They would be independent from the trust, yeah. But they're employed by
I think that, again, going back to the evidence that was presented around from the Muckamore families, they were really, really clear, and I tend to agree with them on this, that independent should really mean independent, and that the trust should have no handle on this. you know, in any shape or form.
And we've had that conversation with some of the families, and we've tried to reiterate they have to be employed by someone. So if the department employed them or held a contract, they wouldn't be seen as independent from the department. If the trust, I can understand the family's view, but there needs to be an employing body or a contracting body of some description. And in reality, it probably is the only way we can do it is through trusts or through BSO or somebody else who is connected in some way to the health and social care system.
Maybe just add to that, I suppose, you know, the trust do have experience of contracting for advocacy services, and certainly my practice experience is when that contract was in place with third-party provider, that they were able to challenge, you know, they were able to speak independently, and that did work reasonably well.
I think it is just such an important issue, and it's such an issue of confidence for the families, you know, given what they've been through, and given all of the issues, and some still ongoing. It's really, really important.
I think possibly for families, you know, an explanation of how the trusts operate their contracts in those sort of cases may well be helpful and reassuring.
I'll just be interested to see how that's worded and so on in the amendment, because I'd really like to see some reference to truly independence, how that works.
I think the amendment will simply say that the provision would put in for independent advocacy in those additional
cases. I'd like to see then further down how that works out and how you actually do that. Because I do think independence is...
It's unlikely that would be on the face of the
no,
bill.
I
That's going to be the guidance
I accept that. Okay. But independence and confidence...
No, absolutely.
Really key. Thank you, Chair.
Okay, Arlia.
So just on that last point, could you maybe elaborate why, when we're talking about the strengthening of the word independence, because that will be important to the families, as Diane says, so why could that not be on, why does that need to be in guidance rather than on the face of the bill?
Well, on the face of the bill, what we're saying is we were including independent advocates. I'm just trying to think the exact clause we were including it in. It was in terms of the serious case reviews. We were going to bring in independent advocates. So we're not actually talking about changing the definition within the bill of independence. That we were actually just saying we were going to include them for another part of the bill. So at the minute they weren't in for serious case review, so we are now putting them in for serious case review. So the principle of independence won't change as such in the bill. So we're not talking about changing that definition within that you will have an independent advocate. I don't think the bill goes into the detail of independence.
The bill doesn't go into a great lot of detail about advocates in general, but that is because we have included a power to bring regulations that would include that detail.
Okay, fair enough. And then just regarding the unregulated professions, so the issue around those being set out again in statutory guidance as opposed to being included in clause 4. It's really just to get your view on whether you think this could have the potential of creating any sort of grey area for, you know, so someone who would work in one of those professions, if they could maybe be unsure around their obligations whenever they encounter an adult at risk, because obviously then, you know, it's only contained within the statutory guidance. And have you had any chat around that?
Yes, we've had quite a lot of chat around that. It's really the policy behind our clause 4, that duty to report, is that we want organisations who are working in health and social care and are engaging with potential adults at risk and those connected with them on a regular basis, that they would have the duty to report. And that is what we have tried to capture. And Mark talked about the amendment to include the lists of legislation that covers the various medical and healthcare organisations to ensure they're all included. What we had to grapple with was that not everyone is captured by those pieces of legislation, and it was difficult for us to get one full list that would capture absolutely everyone. That could end up with a massive list at clause 4 within the legislation that would then be difficult to amend if you wanted to add anybody. So there were challenges associated with that. So what we came to was a balance that we would include those pieces of legislation. That means that anybody who is added to those pieces of legislation will automatically be covered by the bill without a need to amend this as well.
Okay.
And then our statutory guidance will include something of a catch-all that will say where you're dealing with issues like this, you should report that as best practice. Now, although that would not have the same weight as putting it within the legislation, there is still a requirement to abide by statutory guidance, and there's still an expectation that that would be done. That's the balance we came to.
And I think as well, Lorraine, it was we looked at who would have the most contact as well. So for some of the issues covered by unregulated professions will be around audiologists, medical photographers, adult psychotherapists, counsellors, family and systemic therapists and things like that. So it's people who probably have less direct daily contact with somebody who may be classed as an adult at risk. But as Kerry has said, the statutory guidance will say it with best practice for all health and social care practitioners to make that report. So it is a balance between what we can put in primary legislation and the amendments of primary legislation every time a new unregulated profession comes on board or somebody comes up with something new. So the drafter's advice was, if we stick to what's in regulation, put that on the face of the bill and put the other stuff in statutory guidance. So we are following largely what the drafter said. We've had numerous discussions around who should and who shouldn't be on the bill, and this is where we thought we come down with the best option. But sorry, Anya, cut across you.
Well, I was just going to add that so we're naming professionals and on the legislation and in the guidance, but there are also organisations named.
Yes.
So one of the additional safeguards is that for many people who are likely to be in contact with adults at risk, they will have employer or organisational responsibility about reporting as well. Also, one of the things that was considered is that where somebody, an unregulated professional, might be working in a particular setting, such as a care home, there are requirements for the managers to be registered. So, in a sense, all of those, I think, cut down the possibility of us missing something.
Yeah, and that's actually what I was going to ask as well. Then, so if you have the the best practice, that you should follow that. It's the right thing to do in the guidance. But then how you even try and monitor that, which is very difficult, but how people are abiding by what is best practice and what they should be doing. So, even just that last point you made around that role of, for talk's sake, the manager in a care home, having that, I think would be important.
Yeah, absolutely, and there would be both adult safeguarding reporting expectations on them as well, but there will also be expectations from RQIA as well, because care homes are regulated facilities, so there's another layer of monitoring about appropriate reporting as well.
Yeah. Okay, and just finally then, the paper set out that the issue around the prison service not wanting to be named in the bill, and that discussions have been ongoing just regarding that. So it's really just a question around, has a final position been agreed on whether they are going to be named in the bill, and if not, if they don't want to be named in the bill, can the department still make the decision to name them in the bill?
So I suppose it's important to caveat that it's not just they don't want to be named in the bill. The prison service have put out quite detailed arguments why they believe this would potentially impede their statutory duties, because we're suggesting that this could be people who would be outside the prison as well. So there's a number of things where prison colleagues have set out to us where they believe this is outside their statutory duties, and that's part of the argument. It's not simply they don't want to be named in the bill. If we give that impression, that's inaccurate. Apologies. The conversations are ongoing. The conversations at the minute are at Director General level within the prison service and Deputy Secretary level within our department. So we are hoping to resolve it at that level. I suppose we can't get resolution at that level, then it will go to ministerial level or later to try and get a decision there. Ultimately, our minister could bring forward a proposal to include prisons under clause 4 if the Minister of Justice is in disagreement with that, that would be quite challenging then for our Minister to bring that forward. So we do hope to get a resolution to it one way or another, but it is the position of the Transformation Board that the prisons should be named, and you have other criminal justice organisations, the likes of Police and Probation Board and others on the Transformation Board, who believe that prisons should be named, and they were quite supportive of the Transformation Board's position on that. So it's not, as I say, it would be disingenuous of prisons to say they simply don't want to be named. They have set out very clear rationale. That we're going backwards and forwards on. They've also given us a council's opinion now as well, so we will respond to that council opinion. But those conversations are ongoing at the minute.
Okay, thank you. Thanks a million.
Annie?
Thank you, Chair. We've heard time and time again that phased implementation and funding will not work, most recently from the Western Trust there recently at a recent session. What is your response to concerns that phased implementation as it is planned here at the minute will just lead to delays and more missed opportunities?
I think if we had all the money, Danny, to do it tomorrow, we would start it tomorrow. I think the simple position is that we don't have the money presently to do it. So if we're looking at phased implementation, we have been quite clear as well that there are some sort of parts within the bill where we do not believe phased implementation would be appropriate. So there's no point in bringing in forward one power to take a case so far. For example, bringing in a banning order and then you don't have the rest of the powers to continue to do what you need to do in that case. So when we say phased implementation, there's only so much you can phase it, because there will be some bits, the likes of the Adult Protection Board, which is largely a standalone entity. But when you're talking about bringing forward the various punitive clauses, if you like, within the bill, I think they would need to be brought forward as one, and I think we've been quite clear on that. We don't believe you can bring forward parts of those various clauses within the bill where you would be taking a case through the courts. They would all need to come in together, because I agree it wouldn't work if you had a phased implementation in that way. So I suppose it's your interpretation of phased implementation. If phased implementation means we bring everything in the bill in one go, that will be really challenging. But if we can do things which are largely standalone and then bring the other bits in which need to be brought in together, I think that would be our definition of phased implementation.
And another example of that might be that there will be considerable training and engagement with a whole range of stakeholders, and that could be done in preparation in a phased way. That we engage with we engage with care home managers and then another group and another group as well. I mean, certainly the training element would lend itself to phasing.
Okay, just very clear, just the way it's worded there in the pack. It is clear the department intends to implement the bill on a phased basis as and when budget becomes available.
And I say, if we had all of the budget available at one go, we would do our best to go for everything at one time, Danny. But I think even in terms of the implications of that for the wider system, as Anya has said, there's a significant programme of training, not just within health and social care, but within the other partners, PSNI, probation, and others. So I think if we tried to do it in one big bang, for want of a better term, it would be very problematic, I think, to the wider system. That phasing of training and preparedness and readiness of the wider system, I think, is really important in terms of that phased implementation.
And there would also, sorry, Kerry. There's also a workforce supply issue, particularly in terms of social work, which will require some phasing as well to build up the capacity within the workforce so that we have the people who can deliver on the new functions.
I was also going to add that you'll see in the draft implementation plan that we've shared with the committee, there are certain elements that require us to do additional work as a department first. For example, various elements of the bill require regulations to be brought in, such as independent advocates, the setting up of the Adult Protection Board, the CCTV. Those need regulations to be brought in before they could be commenced anyway. So that's also part of the plan for phasing. We would bring those elements in when that work had been done as well.
No problem. Thanks for that. My concern is that some elements of this bill may happen and others may never happen. And I think that has been expressed to us, as a concern time and time again. Just when you were talking about work capacity there, have you liaised with departmental colleagues that are working on the safe staffing bill, just to understand and provide for the workforce implementations that's going to have here?
Yeah, yes, we have. Under the auspices of the general kind of workforce planning function within the department, we have our own workforce planning in place for social work, and in preparation for safe staffing legislation, we are developing the tools to be able to calculate what a safe caseload is for a social worker, and what's a safe workload as well. We have guidance drafted. We've made good progress with that. It too will require a level of resource to implement. But we have done calculations for various programs of care. We haven't got to all programs of care yet, but in our calculation of, well, how many hours might you spend on a complex case, where there may be a safeguarding element, we have built that into the formula for then saying a safe caseload looks like, and we've expressed it as a range. That then feeds into, the calculations we're making overall about what's the overall size of the social work workforce that we need, and that will take account of specialist roles, additional responsibilities, and there'd be a range of those, but one of them certainly would be safeguarding. So I feel we're fairly advanced on that road, but like the general position, full implementation of the recommended ranges will undoubtedly also be gradual and will undoubtedly require some element of additional resourcing. It's not all about resourcing. Some of it's about practice and what do social workers do, and are there other are there other people within the teams who could do some of that. But I have no doubt that it will bring a resourcing demand with it.
Is that worked into the current costing that we were just given there?
The costs of the additional staff are within the costing for the bill, but additional will be needed for any increased supply that we need.
And when it comes
in terms of training places.
Okay. Right, okay. So you've done the calculations and you have a fair idea of a range of how many social workers you're going to need, and that is factored into the cost of the bill.
And it's not just social workers as well, Dan. I think it's important to say that there'll be investigation officers, there'll be admin staff, there'll be minute takers. That's all costed in. It gets down as far as IT changes and desks and furniture and all of that sort of stuff, the full range of costs and that would be necessary. That's why you get to a figure of 13 million a year. It's not just simply staff costs. It is, and as Anya has mentioned there as well, there's training costs, there's legal aid costs. There, the outline case we have goes into a full range of the impacts of this across the whole system, not just in terms of social workplaces.
Thank you. Can I ask as well, one of the things that come up a couple of times, quite a few times now, is human rights. And you're quite clear there that the bill is human rights compliant. Why would you not put that on the face of the bill? Why would you not reference human rights on the face of the bill?
Well, it's simply that we feel that the bill is human rights compliant as it is, and it has to be legally. So we don't feel that it would make any material change to the bill to add that in. Potentially that may be a political decision. However,
you don't see anything wrong with doing that?
We've taken advice from OLC, Danny, in terms of the drafting of the bill, and we haven't had any advice from OLC that we need to be specific on the bill that we believe it is human rights compliant. But we're happy to take that away again and seek further advice from Office of Legislative Counsel around whether we need to be implicit within the face of the bill around our commitment on that. But I say we haven't had any direction from OLC that the drafters thought that was necessary at this stage. But say we're happy to take that away and consider that again.
Okay. No problem. Thanks for that. Thank you, Chair.
Okay, thank you. Al.
Thanks, Chair. Danny was probing something similar to what I was looking to ask, and that is, if, as you say, Mark, you have submitted bids for next year, and if you were successful in those bids, what elements of the bill could we see being implemented first?
We certainly think that the Adult Protection Board would be somewhere we would want to go first. Now, as Kerry has mentioned, Alan, that will take regulations to make sure we can do that. But I certainly think that, because that would replace the Interim Adult Protection Board, which I think colleagues from SPPG were in giving information on there just before we come in. So I think putting that on statute and moving that forward, I think would be one of the things we would move forward with quickly. As Anya said as well, around the training, although that doesn't require the statute to take the training forward. But if we had that programme of training, and then as I said, I think it's implementing the powers within the bill. I think that will be the biggest bit, because you'll need to implement those powers in one block. Would be my advice to Minister, because there is no, as I said previously and today, there's no point in implementing that you can take a case so far and then you want to take it to the next step, but we haven't implemented that next step within the process. So to me, that is largely where you'd be implementing the Adult Protection Board, then you'd be taking forward the training, having all those regs and that in place, that you could then have independent advocates, you could have the training in place. So to me, that would be an implementation, a rough implementation timetable or implementation plan, but we would have to put that to Minister as well, Alan, to get his view on it, and obviously we would take the views of the committee on that as well, and the account and putting advice to Minister.
And just on the Adult Protection Board then, if that is the sort of the starting point that you hope to see, Mark, we note salaries here sitting at what, 396,000. So, for example, what would a chairperson of that Adult Protection Board come in at?
I don't have be in the business case.
I don't have that detail of the business case. I only have the overview of the business case, Danny. But we certainly come back with the range of salaries that we had envisaged for that.
And the members.
I think we had sort of mirrored the safeguarding board in terms of that level of seniority and salaries. But we'll certainly write back, because we have that detail. Sorry, I just don't have it with me today. But we have that level of detail behind it.
And a lot of the members will be attending as part of their, their employer responsibilities as well, and not paid separately.
And then just on the implementation bill as well, we note the reference made to basic training. Now, maybe you touched upon that, Mark. Obviously, we would see that any training involved in this would need to be gold standard, not basic training. Is that just a slip of the tongue, or?
No, I think there's a recognition that, for example, if you take the police service or the probation service or the trusts, we will have a level of training which says everybody's responsibility, safeguarding is everybody's responsibility. But then when you're having people who are taking the cases through the court or the adult protection social workers, they will have a much higher level of training. So it is around some of that awareness training, but then for those individuals who are taking the cases through, there's a much higher level. So I'm not sure, Anya, if you have anything else to add to that.
Yeah, awareness training is perhaps a term that describes it better. It's about tailoring the level of training to somebody's role. I think our scoping identified 6 potential tiers. So, with the top tier being for the adult protection social worker, then for designated adult protection officers, for police officers, and for social workers involved in the joint protocol. So it's tiered according to their function and role, not in terms of the training. We want to provide the right training for everyone depending on their role.
So if it helps, Alan, in terms of some of the costs associated with that, so we have basic training, which is so that low level training we've said around 750,000 over the 10 years, but the more intense training, it's just over £8 million over the 10-year programme. So that is quite intensive training. In the first year, it's about 1.6 million, and then it tapers down as you get more people through. So there is a significant amount of cost in there in terms of the training. So we do want it to be as robust as possible, so those people who are dealing with these cases have the expertise to be able to handle them.
Couple of questions then from me. So in terms of the self-directed harm and neglect, so you're saying you don't think that should be included. You're saying if it was included, the system would be kind of overrun. So I mean, I'm just kind of looking for the rationale or the evidence for that suggestion, because by definition that would say that there isn't currently mechanisms for dealing with that issue currently.
I could maybe respond on that. So, I mean, certainly there would be concerns about the capacity of the system, but I think it's more about what we determine abuse as. So, you know, our definitions are very clearly about, you know, that the harm is being caused by someone else, which isn't necessarily the case in self-neglect or self-harm. There would be, there would be occasions where somebody's self-neglecting or self-harm where there may be an element of coercion or neglect, and those could come within the scope of the legislation. I think there are other mechanisms in terms of, you know, the trust for a referral about somebody who's who is self-neglecting or self-harming, often delivered via mental health services, but within other adult programmes of care as well. Certainly in terms of, you know, our general legislative duties to assess need. It would be routine for social workers or members of community teams to go out to reports of self-neglect, assess the situation, assess the need, look out for any safeguarding implications within that. But the range of responses will be more about mental health support, about working with somebody on a particular issue or motivation as well. So it's not that self-neglect isn't responded to. It would be responded to within the structure of the programmes of care within trust, be that adults or learning disability or mental health. It is particularly complex, area to address, and solutions to it aren't easy, but it's not that self-neglect is ignored or not responded to, and it's really more about it's not the abuse that the bill deals with, because there isn't another person involved.
Okay, fair enough. So a couple of questions then. In guidance clause 22 states the department must review the guidance from time to time. So I think it's important that the department would review the guidance, but I think it's also important that there's a bit of a tighter definition rather than just saying from time to time. So I think you should look at putting in a definitive time period for when the department should review. From time to time could mean never, essentially, and that would be a bad outcome. So I think we want good legislation and good guidance, so I would suggest that you look at changing that aspect of from time to time, put in some kind of definitive, whether it's every 2, 3, 4 years, but I think that would be important. Secondly, then, in terms of amendments, because there's still quite a lot of work ongoing. I know we as a committee intend to start our deliberations on the clauses next week, so we want to see everything quickly. Have you any idea of when we will see all the amendments that you will be proposing?
We're currently working on submission to Minister at the moment to get his views on these. So we are intending to have something up to you in the next couple of weeks.
Okay. Quicker the better. Allows us
Absolutely.
to do our job much better.
I don't think that the amendments are proposed, Chair, substantially change.
Okay.
There's a change in terminology, there's a change around the clause 4, but I don't think other than that, a change in terminology, in terms of the serious case reviews and a change in clause 4, but I don't think fundamentally it changes the context of the bill, but we will absolutely get the amendments up to you as quickly as we possibly can.
And just a question, for just sensing what members have asked in relation to the implementation and time frame. So I'm not saying we haven't discussed any of this, so this isn't, don't take this for granted, but if there was an amendment coming in relation to tightening up the time frame for the implementation of this bill, what would be the view in relation to that?
it's hard to answer that in the abstract, Chair, but I think, and we've said whatever sort of, we will take advice from the committee in terms of implementation as we have from other stakeholders, but I reiterate again that this will largely be based on when the funding is available to do this, but certainly we will take advice from the committee in terms of the implementation plan and the prioritisation of that as well.
Okay.
That had just been answered, Chair. Sorry. Thank you.
Okay, thank you very much. That has been very good and useful to us, so thank you for coming along and taking our questions. Okay, members, we are now going into closed session. So we're going into closed session to take an oral briefing.
It's been 9 weeks.
Okay, so we're back into public session, so can I just let everybody know we're going to item number 8, which is the oral briefing from the Southern Trust overview. Can I refer members to the papers at page 31 of the main pack, and yes, can I welcome Mr. Steve Sporey, Chief Executive, Southern Health and Social Care Trust, Eileen Mullen, Chair of the Southern Health and Care Trust, and Elaine Wilson, Director of Planning, Performance and Informatics. These are all very welcome. Thank you for coming. Thank you also for sending your submission, which we've all read. It's been very useful. So I'm going to hand over to yourselves then just for some additional introductory remarks, and then we'll move straight to questions.
Great. Chair and members, thank you very much. Thank you for inviting us before the committee. We're very pleased to be here. As you've said, you have the briefing document, so our intention is not to go through that in our opening remarks, but however, Steve and I would like to share a few things up front, and then very happy to get into questions with yourself and members. I think a starting point for us is to acknowledge our staff. So we've around 15,000 people that work for the Trust, and every day they do their very best, whether that is in someone's home, in the community, or within an acute setting. So as you'll all know, they quietly get on with their jobs despite the daily challenges and indeed the risks to them, and particularly around assault. So sadly, we've had last year 2,769 physical assaults on our staff, and you know we don't accept it as a norm. We prefer it didn't happen, but we also do acknowledge that in some cases this is down to medication and it is down to associated medical conditions. So we can't ignore that, but it is a high number on our staff, and we do everything we can for them. The next important item I want to cover is around cervical cytology. Steve and I, on behalf of the Trust, want to reiterate our apology to all the women and their families who have been impacted by their cervical screening review. We acknowledge fully the past performance issues in our laboratory and fully accept that the actions of the Trust at that time were not sufficiently robust, and this was unacceptable and a breach of our governance procedures. We will engage fully with Frank Atherton, and post-completion of his work, we will respond to the Minister's decision with the same approach, which will be open and fulsome. Members will recall that the Trust experienced an unexpected IT outage in September, and Steve and Elaine were with you on the 25th to talk that through. We made a commitment at that point to share the report with the committee. The Trust Board received that on the 29th of January, and you have a link to it in your briefing note today. So this is the incident outcome regarding the findings of the independently chaired incident review group. So the root cause of the outage was a result of human process error when a member of the network infrastructure support provider attempted to install the necessary software onto the data centre hardware. And learning from the incident, the Trust has already taken steps to strengthen existing processes and to significantly reduce the risk that a similar incident can happen again in the future. And this includes, for example, dual engineer oversight, which in essence is having a second pair of eyes for work on critical infrastructure components. The Southern Trust, like other trusts, is of course facing enormous and rapidly increasing challenges in meeting growing demands for our services with our current population of over 400,000, and we know that this demand is going to increase in the years ahead, and our older population is set to increase by almost a fifth by 2030, which isn't too far away. And finally, for me, on the money front, the Trust had a savings target for this year of 43 million. We will deliver those savings, and we are forecasting break even for the end of this financial year. We welcome receipt of capital resource allocations around 22 million to assist us with equipment, minor works, backlog maintenance and ICT between now and the end of March. Steve and I advocate at every opportunity for the capital monies in relation to the inescapable pressures regarding fire safety at Daisy Hill Hospital, the capital redevelopment of Craigavon Area Hospital, and movement on the Newry Treatment Centre.
Yes, thanks. I'd like to add to that a little bit. As Eileen said, Southern Trust isn't unique in the challenges it faces. I think they're pretty similar across all the trusts in Northern Ireland. And they include the growing proportion of the population that's elderly, workforce shortages, the budgetary restraints that we face, waiting times challenges, which of course are documented in the briefing, and some workforce shortages, and in our case particularly some buildings that need to be replaced or refurbished to deliver the modern care that we want to deliver. I just want to pick on a few points to highlight. I'll be brief. I mean, firstly, in respect of urgent and emergency care, we're continuing to experience high demand, and consequently our hospitals are under severe pressure. It's lessened a little bit, but we still have people on trolleys and people on extra beds in various areas. I want to take this opportunity to apologise to the patients and their loved ones who've had to wait a long time in the emergency departments and sometimes in ambulances outside emergency departments, and have been those who've come into the hospital and been cared for in inappropriate locations, in extra beds we've put up in various areas. That there has been a reduced flow of patients through the hospitals, and that's led to a lack of capacity for new admissions and consequently the increasing waiting times for emergency department patients. We are already, actually it predates me in some ways, implementing a number of actions based on UK best practice guidance to improve the flow of care of patients and provide alternatives. Notably, they include admission avoidance through the assessment of patients at the front door, inpatient processes such as patient discharge planning meetings, and we've set up single discharge teams covering multiple professions to try and help people find the right location on leaving hospital. In our trust, we've badged those the Timely Care programme, so we've brought them together and coordinated them in one programme. And it's involved a lot of our staff in both the hospitals and community services. But it's clear we need to go beyond that, to be frank, and we need to better understand the underlying causes of the problem. Most notably, really, if I was to pinpoint one now, it would be an increasing length of stay for patients admitted through the emergency departments. And it means that we'll have to think about ways in which we reshape we work across the entire pathway for patients. And from the very first call for an ambulance, for instance, to the social care after a spell in hospital and potentially rehabilitation. It's important, I think, to make the point that those problems are most manifest in the emergency department. They're not caused in the emergency department. And that's why we've got to look across the entirety of those pathways. We're also aware of the impact of unacceptably long waiting times on some groups of elective patients and their families. And as you know, we've included a lot of detailed information about those waiting times in the briefing papers. And they cover the range of really services, including outpatients, inpatients, diagnostics, cancer services, mental health and children's services. I know that members have been particularly concerned about breast cancer assessment waiting times and the latest regional quarterly waiting time statistics. we believe the move to the regional waiting list and coordinated services will start to address some of those challenges. We're making progress towards meeting regional waiting time targets using that single list. But I won't say more than that now about elective waiting, because I suspect you may have some specific questions you want to follow up. The final thing I really wanted to highlight was the recruitment and retention of staff, because this remains a significant challenge in relation to some services and some groups of staff for us. I think notably medical consultants in psychiatry, gastroenterology, obstetrics and gynecology and haematology, and also in fact social workers. And we do face some particular challenges because of our border location and more attractive employment conditions being offered to the south of us, to be frank. On a brighter note, though, I'm pleased to say that we recently appointed 4 consultant radiologists in one go, and that will help to improve waiting times for imaging. What's particularly great about that, the reason why I wanted to mention it, is 3 of those doctors were originally recruited some time ago as part of our international recruitment initiative. And what's happened is our existing radiologists worked with their new colleagues to develop their skills so that they became eligible to apply for consultant posts. And so we've now got those people in those posts, and they've decided they want to stay with us and work with us. And I'm highlighting it because I think it's a really good example of how to address a serious issue in a systematic way. And it also highlights that developing people pays dividends, real dividends in terms of service capability. And similarly, looking at nurses, we've significantly reduced our use of agency nurses over the course of the past year. And to some extent, we've also reduced the use of bank staff hours. We've done that by recruiting newly qualified nurses in greater numbers, being more flexible in the way we deploy people, so we can't send those newly qualified nurses straight into the most difficult areas without supervision, of course. But it's had real benefits. We've reduced the overall numbers we're deploying on duty. It's good for patients because it improves the continuity of care. It's good for the youngsters that we've taken on who wouldn't have had jobs. And it's good for the budget as well. So again, I'm highlighting some systematic work in terms of developing people and deploying them correctly. Produces real dividends. But I'll conclude at that point, and we'll look forward to answering your questions.
Okay, thank you very much. Can I just begin by saying that I think the apology in relation to the cervical cytology sampling was warranted and merited. I mean, particularly for the impact that has had on those women and their families. And I mean, it's a black spot on the work of the Southern Trust. I'm not going to ask any questions in relation to it, but I just wanted to make that point because I know others will certainly ask questions on it. So, I mean, I just want to start a bit on some of the other aspects. So each of the trusts was asked to make savings. So, I mean, if I could ask if you could maybe outline the level of savings that the trust has made, and you know the impact that has had, or the impact that it potentially could have in the work that you're doing.
Yeah. Perhaps if I start, and I suspect Elaine might add. So, as you heard, we were asked to effectively save £43 million. We had an initial budget, and then during the course of the year, that budget was reduced a bit by £16 million. And we believe that we will meet the reduced budgetary target for this trust for this year. How have we done it? Well, some of the measures have been specific work programs to achieve savings. So I alluded to, for instance, the big savings that we've been able to make in terms of our use of agency staffing through substitution. We've made great strides in nursing. We've made some progress with medical staff. We've got more to go at. But it's that kind of thing. We've made some savings through the initial implementation of Encompass, but we expect to make more. We're obviously only implemented in May of this year, haven't we? We've had a range of savings targets to achieve savings on our procurement programs and on our use of contractors, and we believe that in particular our emphasis on sustainability has reduced some of our revenue costs supporting the estate, while at the same time contributing to a greener future. So there's a lot of systematic work. We have, though, also had to do some things in targeted areas about slowing down recruitment. So not replacing some people, but asking other people to cover 2 jobs and accepting some loss of activity. That's largely as a result of this second steeper request, if you see what I mean. When you get something coming at you part way through the year, it's difficult to, you haven't got time to plan for it. You've just got to look at what levers can I pull right now to save money right now.
I don't want to, I want to interrupt you, but because we've got a workforce problem in one hand, and secondly, you're telling us to achieve savings that we're adding to that workforce problem, and that we're not.
I think that's where you've got to be clever about it, which is perhaps what I was trying to convey in my opening statement. We've got workforce shortages in some areas. We've got a potential to substitute for existing workforce in other areas. Encompass, we haven't really got into the much vaunted AI yet, but we'll move towards that. And we've been able to show some savings on our estates provision as well. But it's a tough call. The other thing, though, that I wanted to emphasise is I've been with the Trust for 10, 11 months now. I've definitely seen an improvement in managers generally managing to budgets, using financial information, understanding what's happening. It's a past experience of financial turnarounds actually in big English trusts. A lot of floating off the rocks comes if you get lots of people managing their budgets just a bit better. And I've tried to take and encourage that approach, and I believe we're seeing some dividends from it. I don't know if there's anything you want to add, Elaine.
I think you've covered it off very well, Steve. I suppose just to be clear in terms of the delays to recruitment, those were not in frontline staff, so no nursing or medical staff. It was the other specialties that we delayed the recruitment of those to make some savings. And we have made really good progress in starting our Encompass savings programme, so we think there's real potential there, but we've got a fair bit out already.
Okay, so you'll be aware that we had the independent care sector and a number of weeks ago, and we did permanent secretary and last week. So this is a major issue for the health service. It's something that the health committee are looking at, trying to look at in terms of detail too, because of the issues that you're talking about, hospital flow. So there was some suggestion from the independent care sector that some trusts were trying to create savings by not fully implementing care packages within the community. So I'm just going to state that and maybe ask, in terms of your own trust area, do we know how many people are currently in hospital who are waiting for a care package, or who are sort of delayed in terms of getting out, and what kind of work is the trust doing to resolve this issue so that we have a better flow through the hospitals and that we have better community and care?
Yeah. So we're talking about the independent care sector here, aren't we? So about 3 weeks ago, so I haven't got the latest numbers for you, but about 3 weeks ago, we had 840 people waiting for a package of care. That means some sort of help at home.
Yep.
Okay.
840 people in hospital?
No, 840 people, the overwhelming majority of whom are not in hospital. And at that stage, we had just under 100 in beds, of whom only a small number, I can't remember, were in our acute beds. But bear in mind, we've got community health beds. And one way in which actually we do look a bit different to the other trusts is we have significant number of residential beds in our own bed stock. So one of the big pushes we've been having, actually, going back to what I was saying about improving flow, was if we can't get them home, at least get them out of the acute hospital beds and into our own residential beds. So that's where we were about 3 weeks ago. But I'm sorry I haven't got the latest numbers.
Okay.
But I think the pattern won't have changed a great deal, to be honest.
Okay, and the unfortunate thing with these sessions is I could probably ask about 10 follow-on questions, but I've a number of issues I want to kind of get through. Workforce is an issue right across the health service. So, I mean, I actually engaged with a midwife last week in a different trust area, very concerned about staffing levels and the impact on staff, but also on the impact on service. So, I mean, what are we doing within the Southern Trust in terms of, I know you did give some detail about recruitment. Is there particular service areas where workforce, for example, midwifery or other service areas where it's a particular concern, and is it having any impact on service delivery?
Well, midwifery was a big concern for us, and it was part of the story about concerns about Daisy Hill's service 18 months or so ago. So that's been an area that we have concentrated upon. We've made significant progress now. I can't remember the precise numbers, but the number of vacancies on both the Craigavon and the Daisy Hill sites has fallen very significantly. So we feel in a much more robust place, if you like, in terms of midwifery service, and we've got a very good new leadership team around that service, that obstetrics and midwifery. So that one I'm feeling we've moved in the right direction. And another one to illustrate, I think I mentioned briefly, shortage of social workers. Our Director of Social Services has done tremendously well in recruiting new qualifiers. We've taken on just over 40 in the last year. Tremendous progress through him and his colleagues reaching out to the new qualifiers, providing good placements for them, etc. We've still got vacancies. We'll be in a much better place. We're in a bit of a lumpy time for a couple of years because new qualifiers quite rightly have to have a lower caseload and more supervision from the experienced staff. So we're asking for quite a lot of our experienced people. But the good thing about it is you can see the light at the end of the tunnel, if you like. So that's another example of what we're trying to do. If I could just say on a third one, you'll be aware this trust, in common with the others, have formed this committee in common. Two of its early work priority areas that we were particularly pleased about were haematology and psychiatry, which are problem areas for us in recruitment. But I think we need to get into looking at the workforce across the region as a whole, and coming up with a strategy to deploy them appropriately. And I'm very hopeful that we'll get more transparency and accountability to trusts about the numbers of medics being trained. I'm told the psychiatry problem was visible a long time ago, and we didn't up the numbers. Well, I think the solution to that kind of problem is transparency. Actually, is making it clear to everybody what's happening.
Okay, and then my last issue is on the waiting lists. So you expected conversations with regard to elective surge or waiting lists. So I'm going to ask a brief question in relation to that, and essentially, what impact, of any, in your trust area, the 215 million and has made, and then particularly around cancer waiting lists. These are time critical services. So I would be very interested to hear your assessment of what is impeding your trust in terms of keeping to the 30 and the 60 day time frame.
I'll defer to Elaine, who has the detail on how we've spent our share of the 250 million and what it's done for us.
Yeah, okay, thank you. So we had 6.5 million that was focused on our inpatient waits from the money, and that has treated 4,000 patients, or it will have by the 31st of March. And at that point in time, in relation to the named procedures that the SPPG has set up, we won't have, if we have a couple of maybe waiters at that point in time, there'll be a very specific clinical reason for that. The rest of them will all be through the system. We also spent, or will have spent, 16.9 million in relation to seeing outpatient appointments and some inpatient as well, beyond those 4-year wait people. So there's the red flag and urgent waits, which would link into the cancer that you've referred to, and we'll have seen about 40,000, just over 40,000 patients additional with that money. That is a mix of independent sector use plus also additional in-house capacity, and we've also been doing a big piece of work on our validation of our lists, which we found, although we always do validate our lists, we start with admin validation, which is the checking, do you still need the appointment and that sort of thing, and then we move on to the clinical validation to check that you definitely still need the procedure or what you're waiting for, and the piece of work that we did on that actually reduced our waiting list by 40%. So there are a lot of people on these waiting lists that when you validate that they don't need to be there, and I suppose what that has done for us is made sure that the people that we are treating with this money, that we are treating the right people who really need it.
Just because that's very interesting. That's a big figure, 40%. Do you collect data about why they're coming? No, is it because they've got paid privately, they no longer suffer from the condition, or potentially, unfortunately, maybe passed away? Do you collect that data?
We don't have that data at that level, but those are obviously reasons why people will be taken off the list.
40%, that's a
now that was for a list of named procedures, not for everybody, but it has made us realise obviously it's really worth investing money on doing that validation process, so we've been spending more money on doing that.
Just to add, not surprisingly, the longer the waits, the more you weed out if you then validate. You know,
okay, fair enough.
So 40% sounded very high to me from an English perspective, but then I remembered the waits are shorter. Yeah.
Okay. Sorry, I interrupted you there.
That's okay. So in terms of the numbers that are taken off those lists, obviously that is going to put us in a more positive position in relation to some of those cancer waits that we've got. I suppose our issue, if you look at our statistics, the 14-day red flag breast weight, some of that money was used to reduce that list down. You can see that our performance is improving, but we still a way to go. I suppose part of our issue is that we can see patients, and we do well against our 31-day pathway, which is getting people seen to decide do they need a procedure. Not so well against our 62-day pathway, because that's when people need treatment, and that links into the staffing issues. So if we look at the areas that we're not performing well in that, it's the likes of haematology, gastroenterology, dermatology, the places that we know we've got staffing issues. So we've been trying to do some reform work around those. So not only are we targeting this investment to get the independent sector to take those waiting lists down and show improvements, and that absolutely has been doing that. That's not a long-term solution for us. We need to work out what the long-term solution is. So we will see in the likes of gastroenterology that our 9-week waits will now be complied with by the end of March, and that's a really positive position, but that is because of this significant additional investment that has been put in, and a lot of that has been within the independent sector. So we're now looking at how we sustain our services and reform them as well, not just trying to recruit into people, but how are people being used in terms of their skill set and maximising people's skill sets within that. So significant amount of work to try and reform as well.
If we're bringing the waiting list down purely by using the independent sector, when we can no longer afford to pay the independent sector, and we don't get our workforce right, those waiting lists will...
There is a risk that will happen. Now, those numbers I've talked about, not all of that's the independent sector. We have also been looking, particularly in some of those difficult specialties, about how we reform and change how our clinicians are delivering their services to try and increase capacity. So in some of those more difficult areas, we have increased in-house capacity as well. But it's never going to solve the issue of the rising demand. We know that the demand keeps rising, and even with the independent sector, it's very difficult to keep that rising demand down. So we will absolutely need to sort that out ourselves in-house, but we will always need some level of waiting list initiative monies, I think.
Okay, thank you. Linda?
Thank you, Chair. Just on the back of that last point around the need to recruit staff, so was any of that waiting list money used to recruit into those specialties that you have specific issues around, so gastroenterology, the breast services, things like that?
So we have the money to recruit into those in our baseline, so we don't need the waiting list money to do that. We have continual recruitment that goes on to try and fill those posts.
The recruitment was not slowed down in those areas where you have...
And we have had some success in terms of the likes of our breast team with a new breast consultant starting on the 1st of April. So there are successes in the recruitment, but there are some areas that it's just really difficult because the workforce just doesn't exist in Northern Ireland, which is what Steve had suggested in terms of looking at some of these areas as a whole. You know.
So the Minister's outlined obviously his first stage in terms of breast services was to move to the regional list. Has he had any conversations with trusts, or have the committees in common had any conversations about whether there will actually be a regional service that will really bring the wait times down, or is the plan, as you're aware of it right now, to continue as we are?
I think we're at the moment continuing as we are. The committee in common is not at the moment looking at the breast service because the commissioner, the SPPG, took the lead in this particular exercise. It just muddied the waters if they got involved when somebody else is in charge.
Well, and that's fair.
Yeah.
So I have a couple of specific questions then. The cervical cytology samples that were not reported, I think it was the 15th and 16th of May, it's in your report, and I had asked the Minister a question. I know you've referred to that in your report. We had, you'll see in the correspondence, Chair, that I had written to the Minister to ask what happened there, and I got a response that tells me nothing, just to be honest with you.
Never.
And I'm just wondering, maybe we don't know yet, why, was it a specific Southern Trust area problem? Was it between the GPs and the Belfast Trust where the results now go to be tested? Do you know where that where the problem has happened there? And if we know where it's happened, how can we ensure it doesn't happen again?
I think, we in conjunction with Belfast Trust have carried out, I think it was a serious adverse incident review. It's a joint review. So in other words, what happened? The problem is not with the GPs. We can be certain of that. They were collected from the GP. The drill is they're collected by our vans from our collection points. We're collecting lots of samples, most of which are being processed within our laboratories. But we also collect the samples that go to Belfast, and then they're taken on up to Belfast, if you see what I mean. There's no point in them sending out a separate collection round Northern Ireland. What the last part of that review, or the last version of that review that I have seen, basically concludes it's not possible to say, did they definitely arrive in the Belfast lab and were lost in the lab, or did they get lost in transport from Southern Trust to the Belfast lab? That's a real pity and a real shortfall in the in the way in which we track the samples. What we really wanted to know was it a problem with the transportation, or did they get lost once they were in the labs? They were delivered and lost in the labs. And we can't answer that question.
Can we get some detail, because what the Minister's response doesn't give me is detail on how that will be addressed. I mean, I'm assuming that this could potentially happen then in any trust where the samples are going to Belfast. So my main concern here is that not all of those ladies have come back for repeat cervical smear yet. As somebody who's just been through the process, it's not pleasant. Yeah. I would go back 10 times if that's what it took. But many women will not, for lots of different reasons. It's not comfortable, it's not nice, it's not easy, and it's very much an individual thing about how comfortable or uncomfortable you are with the process. My reasoning for saying I would go back 10 times is because I've seen the outcome of not going back. But not everybody has had personal experience of that, and maybe just don't, think I don't want to put myself through that again. So I would be really concerned, and I would want to know what is going to be done to ensure that process is tightened up, that we need detail on that. I'm not asking you to give me that today, but I absolutely need to get detail on it, whether that comes from yourselves as a trust or whether yourselves working with Belfast Trust. An answer needs to come back to this committee on that specific issue, because I am really concerned. Thankfully it was picked up and those ladies were offered the opportunity at least to repeat, but I am concerned that I think it's 18 of the 68 have not. I think were you going to come in there, Eileen?
Was it, if you're finished, Linda? Yeah.
Yeah.
So the numbers that I have, 64 were missing in total. 50 women have come back. There's 14, and we would encourage them, and we're continuing to encourage them to come back.
And I know one is expecting mother, so she's
there's some obviously personal on the process piece. This what has happened here doesn't instigate a major change of how samples are collected, recorded, and taken to where they need to be. If that doesn't happen as a result of this, then we're missing a huge opportunity. The fact that we can't, they're not being scanned, there's no barcode, all of that in a system as small as what we have, that shouldn't be the case. So that there needs to be a dramatic change here of how these are recorded, dispatched, and received, and that should be done in a very simple electronic way to prevent this from ever happening again.
We get the detail of how and when that is going to be done, because that until that's done, that's a concern for us, and it's a concern then for every trust. If you know, if that can happen within the Southern Trust, there's no reason it can't happen in another trust area. So I mean, I'm not going to go into the detail of the cytology review. Frank Atherton review is happening. I want to see what the outcome of that is, and I know obviously the ladies have their own concerns and want the public inquiry. So I think that you know, this is their issue, and it is for them to lead on, in my view. So just on the capital projects, just a very quick response. Have you got any indication yet from the Minister around those business cases and whether the Southern Trust is a priority? And I'm thinking specifically around the ones that you've identified within the report, but Craigavon Area Hospital being the main one.
No.
No indications?
Short answer, we've been...
Even a time frame as to when they might?
No, I think
because
of the overall big budgetary issues.
And that's fine.
We were asked to prioritise them, Linda. You know, which ones would be top of our list. That's the last contact we've had. Okay.
Just on the IT outage then, is there any opportunity for the Trust to actually, I suppose, come to some arrangement with the provider around the contractual obligations that they had in terms of ensuring that this did not happen? Are there any opportunities for the Trust to claim that back from them? Or is there any conversations ongoing?
So we are currently exploring our Centre of Procurement Expertise, and our legal advisors are looking at the contract at the minute to see if there's any contractual recourse and having those discussions with the provider.
Okay. And do you think, is your legal advice saying you should have, and are they pushing back as a provider?
At this stage,
and are they providers for other trusts?
So yes, they are providers for some of the other trusts. At this stage, we haven't gone down through the litigation process of we're waiting to see, I suppose, what those discussions between the procurement advisors, our legal teams and their legal teams in relation to what they might offer. And then we will consider whether it's worth going down through that litigation process.
Yeah.
Okay. And I mean, that should be a consideration in terms of any future contracts from any trust.
Yes, it would be.
About their own obligations and
their reaction to
and how they honour those obligations. I think that's really important, and we probably need to get a sense of that. Just women's health has been moved now to children and young people in women's health. Is there rationale for that?
Yes. So it's part of a package of changes we've just enacted. Part of it is of course, you know, in terms of newborns, there's a close relationship between paediatrics and obstetrics. So they're services that always have to be co-located. So if you're looking at clinical synergies, you know, I'm used to seeing it in other trusts as services that are grouped together, if you like. Another reason is, to be frank, our leader of our children's services, who's also our director of social services, has done a very good job, and in a variety of ways, and I wanted to strengthen the leadership being given to women's services, and that it was part of that, as well as recruiting some good quality people to work with him. So I think that will produce some benefits. And we've also brought in some new leadership around our adult acute and community services to deal with some of those problems about flow and access that we've been talking about. But to be candid, it makes that job more doable if I take women's services and put them with another experienced leader, if you see what I mean. So that was the thinking.
I think if Colin does as good a job around women's health as he's done around children's services, I would be very pleased. And I had a question around social workers, but to be honest, you have addressed that. Just in relation then to the two other questions, sorry, Chair. Daisy Hill, and I think it's worth acknowledging the work done by the Daisy Hill Futures Group, which obviously included the Trust as well, and those conversations, because that has shown that positive outcomes can happen when everybody works together. That's people in the community, elected representatives. So I think it's really important. And I mean, we've seen the positive outcomes in terms of the maternity services, in terms of the additional work that has been able to be put into Daisy Hill. So I just want to acknowledge Daisy Hill Futures Group in relation to that. My last issue is around the physical abuse incidents and the number of them in Craigavon Area Hospital. So just to understand, does Craigavon Area Hospital, I know there's a column that says other, is that only the community? Does Craigavon Area Hospital include Bluestone in their figures? And at some point, could we maybe get a breakdown of, you know, what areas those figures are happening? I mean, we can make an assumption that the majority happen in ED, but they don't all, to be honest with you. I just would like to get an understanding. But I mean, they're higher than any of the other acute hospitals, including Altnagelvin and the Royal, which is really, really concerning. So no, we had spoken to Jennifer last week about, you know, the Royal and the Belfast Trust considering whether they would bring in the body worn video, which is in the Northern Trust, which actually has one of the lowest incidents of physical assault. So is that something that you're considering as a trust, and specifically for Craigavon?
We're considering it for. Do you want me? Sure. We're considering it for both Craigavon and Daisy Hill together, actually. So we're not distinguishing. At the moment, our security porters wear body-worn camera, but it isn't on. They inform somebody they're going to turn it on, and that normally causes people to adjust their behaviour at that point. So we found that as a more effective route. Our mental health staff have body-worn cameras as well. Other staff do not, so it's expanding elsewhere. We do have CCTV and make prominent reference to it, so people know that, you know, there are cameras on in public areas and treatment areas, some treatment areas. We have a policy of hot and longer term debriefing and counselling, so when staff are subject to incidents, they're seen immediately, so we understand what has happened, and then there's follow-up with them, with management, a referral to occupational health, and access to a counselling service if they wish to take that up. We provide handling aggression training, but our uptake, this is an issue for us, our uptake is very variable by staff group. So our mental health and learning disabilities staff and our community staff, who are often lone workers, very high uptake, 95% plus. The acute hospital staff, significantly lower uptake, 20%, 20% range sort of thing. So that's something we need to work harder on, to be candid.
Is there a plan in place to try and look at that and have specific, I suppose, targeted actions in order to address that. I mean, those
Yeah,
figures
I mean,
are
in terms
really,
of-
really concerning when you look at them, even in comparison to the other hospitals. Like they're double what some of them are.
And the first area we're looking at are the 2 emergency departments, both in terms of cameras and training.
And in addition to that, Linda, if I may, some of the incidents are in wards, so we have to factor in that this isn't all about emergency departments. Jennifer was with you last week and she talked about going to consultation, which their board has just agreed. And I'm in full support of Jennifer, and I spoke about it in relation to if one trust has gone through this process, why are 4 other trusts having to do the same thing? And we do it once for everybody and it just applies, and that would be my view, and we should be just pressing ahead, and this shouldn't be a 1 dozen and then 4 has to go afterwards. So I'd be very supportive of that, and hopefully whatever conversations are needed to make that happen can take place.
And we actually write to the department specifically. We may have done it from last week's conversation, but just to, I'm really, really concerned that those figures for staff in Craigavon area hospitals really distressing.
That makes sense, that approach. Okay, Linda. Diane?
Yes, thank you, Chair. And thank you for coming. And I suppose, first of all, Southern Trust is the heart of my constituency. So it's one I probably know better than most. But thank you also for all that's done within the trust area. Sometimes when you come here, it's all the problems that we highlight. But there are very good things day by day by day. So I just want to say that. I think that your apology again in relation to the cervical screening issue is very, very important. And it's quite strong and robust apology, and I do think that that is important. But this is a situation where 2 women have died. Others have been through very, very significant procedures and a lot of trauma. And maybe I am missing this, but who has been held accountable for this? What accountability has the Trust demanded of senior managers who failed, and all of the issues failed to actually look back and trace a programme of underperformance and the resulting issues that have arisen? And there are women today who have been through cancer treatment because of this issue. There are women who are not here, and there are families who don't have mums. So who has been held accountable?
So, Dan, I'll take that in the first instance. So you appreciate, I personally have come in at the late end of this sad story.
Fresh eyes might be a good thing in this
well,
story.
fresh eyes. To be candid, there's been a series of reports commissioned, of course, on this.
Yes.
And I find it difficult to understand the totality of it because they've been done as discrete, separate reports. So I and the board are very interested in what Sir Frank Atherton comes back with, because part of his remit is to look at the totality of it. And that will enable us to inform better judgments about specifically at what points in time and who were involved with things going wrong. I could speculate because I've read quite a lot about it, but I wouldn't place much faith in my own speculation. It's also difficult to hold individuals to account when there's a process of review going on. If you see what I mean, we could be told you might find out further things later on. So I think that's the real reason. I, though, do accept the strong feeling about that, and I understand it. We offered all of the women who, the 12 women who were the subject of personal adverse incident reviews, the chance to meet with us. 2 of them did so. Both of them said effectively what you just said to me. So I take that point.
So, and while respecting your explanation, I think that the answer then that you gave me is no one has been held to account to date.
Not so far.
I think that's appalling. I mean, the women who will listen to this will be astounded that this could have gone on. 17,500 women could have had their smears reviewed. Women have died. Families are without mothers. I personally have attended some of the SAI briefings, and no one has been held to account. I appreciate your honesty, but I think that that's part of the problem with the health service. Accountability is a huge issue, and I think that's part of the problem. I have a range of other questions, but I did want to get that in because I feel strongly about it. I've met these women numerous times. I live beside them. You know, they're my neighbours. And I do think that reviewing the reviews isn't really the issue that they want settled. They want to know why it happened and who's accountable. Couple of things other that I think are important, really important. Eileen, you and I have spoken about this, and I do think in light, and when I spoke to you about this, I actually didn't have the waiting list figures that you very transparently provided within the briefing, and I think it's important. We now know that some of the services are, specifically gastroenterology, is now within this special framework issue. It's not at the highest level, but it is within that special framework, and that is because of the level of weights in terms of gastroenterology. Sorry, I have to get logged on here. I was looking at the figures for red flag appointments for gastroenterology, and they're incredibly high in the Southern Trust. And the waits then for those people who are waiting a long time, I think it's about 174 who are waiting years actually to be seen. So specifically, what is the intervention? How are you going to resolve the issue? And what's the time frame to resolve the issue? Now, I know you're going to say we need more staff, and that's the answer to a lot of it, but we really need to get this under control.
So, in terms of dealing with the red flag patients, which is a real worry, I'm pleased to say that with the SPPG's funding support, we've contracted with the independent sector to provide additional capacity.
So just what will that mean? So you've said that in gastroenterology there's 8,470 waits. The longest wait is 8 years and the median wait is 69 weeks. What does that mean for the waiting list?
So the red flag patients that's the total waiting list. So that includes urgents, routines and red flags.
The red flag one is particular. It has
is
959.
that's the most frightening in terms of clinical risk.
Yes.
So we are concentrating on the red flag group first.
Okay.
Okay. Our objective, using the independent sector, is to remove the red flag weights from the waiting list by the end of March. And we're on target to do that now.
So that will be 959 people removed from the waiting list by the end of March. That's well.
All right. So
if you've been kind of waiting, I mean, the longest red flag waiting list here is 20, or the highest grouping is 188 people waiting 26 to 36 weeks, 3 years on a red flag waiting list.
We've got to do more than that. But I'm just saying to you, that's the first step. And it's dealing with the highest clinical risk group of people. Of course, if we just stop there, the list would just grow again and we wouldn't address those other people. So it's a first step, it's an important step, but it's step number one. What we are doing in addition to that is we now have an agreement between all the trusts of Northern Ireland that the other trusts are each taking 20 referrals a month to us to treat. to stabilise the position a bit. So they're each taking 20 a month, and that will be a recurrent pattern through next year. And we're very grateful to them for their help in doing that. Okay.
And how are you building the workforce though in Craigavon? Because which is the fundamental in all of this.
It is absolutely. That's the bottom line. So the way out of this is we're currently just below 50% staffed for gastroenterologists. That's the real. That's the real underlying problem, and that's why I mentioned that group. Now, talking to the consultants, we've got ourselves into a doom loop, to be frank, of it's difficult to recruit because the working environment's so difficult, because there are so few gastroenterologists and such long waiting times. So if you're coming out of training, it's a difficult environment to go and work in. Now, I'm pleased we've got another recruit recently who's yet to join us, but we need some help with that. Our consultants and the trust have jointly agreed that we will invite in external reviewers to help us understand what's wrong with the service and how we can chart a way out of it. The SPPG and the other trusts in the system have said they're prepared to help us once they see the outcomes of that review. So I don't want to prejudge what it might say. I think it's the right thing to do, that kind of intervention. I have seen it used before when you've got a service in trouble. So we're doing that. We've got further options that we are exploring about using the independent sector in 2 different ways during the course of next year, because of course we're not going to recruit back up in time to sort out next year. I don't want to say more about the specifics because we're in negotiations about them, but we will need significant help next year to manage that workload.
Even if the other trusts are taking 20 patients a month off you, that's 80 patients on an awaiting list of 8,470. That's not going, and people joining that waiting list, that's not going to make a huge difference. Can I just, and I'm just conscious of time, so just to go through, there's a couple of other things that in relation to the waiting list, and I do appreciate the transparency around them. I think the more honest we are, the more we can get to grips with the problem and try to solve it. In relation to that, I had a constituent who came to me this week, and she has been waiting 7 years on a urology appointment. She's at Wits End Corner. And you have 2,651. The longest wait is 8 years, and the median wait is 77 weeks. The red flag, you have 60 patients on but relative to the 8 years, a shorter waiting list. Are you what are you doing about? I mean, because the waiting lists in Guinea are 10,500 people waiting, an average of 5 years on an appointment. Those are huge numbers.
Huge numbers, shocking numbers.
And I mean, those are huge programs of work. I just think that we really do need to try and work through those waiting lists. And workforce can't be the excuse for everything. It just can't. It must be the way some of them are managed, etc. But I am glad to hear that in terms of the gastroenterology, that you will have reduced the red flag one. That also is really significant. Care packages, 840 care packages outstanding. I noticed in a question that was actually asked by my colleague Diane Forsyth that in the number of domiciliary care worker vacancies, the Southern Trust had 191. I'm presuming that's because you employ a lot of your domiciliary care workers as opposed to them being outsourced.
We provide about 40% of the packages in-house. Just on the workforce, what we find is if we recruit very actively, we denude the local independent sector. You see what I mean? The people we recruit come from the independent sector or the other organisation we're contracting with. So there's a problem of we're all fishing in the same pool.
And just finally from me, the capital build programme for Craigavon Hospital. I mean, I'll be over this week again, seeing family. But the issue of a new build for Craigavon Hospital is becoming ever more important. Now, I accept entirely that there's a lot of calls on the minister's budget. I accept that entirely. But what discussion have you had with the estates team? And what is the top line thing that you need to get the Craigavon issue underway, at least, and in some shape, so that it can be considered for a capital allocation?
We need a small amount of capital next year and a bit more the year after, because what we've got to do is to start really planning what a new Craigavon would look like. Okay, and my pitch to the department is it's not very much money in the scheme of your in the overall total of your capital budget, but if we don't start next year, we've kicked the can down the road another year.
Yes.
So that's what we really need.
What sort of money are we talking about out of a capital budget of multiple millions?
Yeah, I mean it's little more than $500,000 next year. It's really.
But it allows the process to begin. Start.
You know, the first. I don't want to build up people's expectations. We'll have to do several years of planning before you see anything happening on the ground. And you know, the first phase will be to really understand the condition of the estate as it is at the moment, what it's actually being utilised for, and then to get into an exercise about what would a Craigavon in 20 years' time be doing, and then from there to begin the process of beginning to plan footprints and sizes. You know, so it's quite a long process, but you know, if we don't start, we don't get there.
I think the important thing to say about the first initial investment we're asking for is it's looking at the whole of the trust and how we transform our services that will then inform what Craigavon needs to look like. So that's the bit we think is really good timing in terms of the financial environment we're in, the workforce environment we're in, the increasing demand on our services, the growing elderly population. All of those things mean that we need to start to transform how we deliver across all our sites, and that piece of work would start to give us answers on all of those things. So we're really keen to move it forward.
We are. Can I just one thing, personal observation? I came here from a London hospital built in 1974 to a Northern Ireland hospital built in 1972, and it was Daisy.
71.
71, yeah.
Same age as me.
Yeah.
I was born there.
Well, it's striking how much better maintained the hospitals here have been, to be honest.
Although it wasn't much cold comfort for the patients where the windows blew in round them in the storm last year. You know, it's.
We need to move on. So
we're in a strange situation. Okay. Anyway, thank you,
Danny.
Thank you, Chair. I want to agree with others that the apology that you gave at the start of this presentation was very appropriate. And you may be aware that this committee have expressed a view that there should be a public inquiry with powers to compel witnesses, and we hope that the Minister will deliver this for the women and their families, and that there is truth and accountability for the women who have suffered. Just to go into a couple of questions, and a lot of the areas I was going to go into have already been covered. You mentioned the new nurses that had been taken on. Can I just ask how many of these new nurses there are? Are they full-time substantive posts? They're not bank posts, they're not part-time, they're not anything like that. And what is the breakdown if they are?
We're looking through our papers to see if we find the number, but it was just over 100. They're overwhelmingly full-time because they're new qualifiers, youngsters who want to work and get the experience. So
they're contracted positions. They're full-time contracted positions.
Yeah. Yes.
Okay. All of them, or the majority, or?
I'm not prepared to say all of them, but the overwhelming majority are full-time contracted. It may even be all of them. because that's what they want when they're coming out of training, most of them, and one or two of them might have family commitments and so on. And we want as much of their time as we can get, of course.
Yeah, absolutely. And what we're hearing from student nurses is that at times they're not being offered full-time substantive posts, they're being offered bank posts, they're being offered part-time posts.
Yeah.
So I just wanted to clear up. Now, obviously, it's great to hear that you've taken on so many new graduated nurses. The start of their careers, it's wonderful to hear. But good to hear that they are substantive posts. The savings you mentioned due to the implementation of Encompass, what are these? And are they year-on-year savings or?
Well, I'll perhaps defer to Elaine, but in doing so, I'll say this. This is the very first phase of savings from Encompass. Bear in mind we've only had it since May, and we're going to go looking for a lot more. But I'll hand over to Elaine at that point.
Yeah, so at this stage it's obvious things like reduction in printing, so we're not printing as much, and we've had quite a lot of savings actually in relation to that. Reduction in consumables that aren't required anymore in relation to the way that we're using our system. We've also had quite a big cohort of staff who we didn't need anymore that we have redeployed into other posts, so we haven't made anybody redundant, but we have put them into other vacant posts. So that was the big piece of the saving this year. So those are all recurrent savings, but they will also grow. We would like to really start to push Encompass to drive really significant savings out of the Southern Trust. We also made significant savings in relation to pharmacy this year. Now that is part of a big wider pharmacy improvement programme that had been going on anyway, but we know that Encompass is helping that and is making those. So we made a significant more savings in relation to pharmacy than we had projected in year, and the contribution of Encompass had to be recognised in that. So again, we think there's real opportunity to take much more pharmacy savings out of the use of our Encompass system. So it's one of our priorities for next year, is to really drive that system to get savings, because obviously that's a much more preferable place to take savings than having to start to look at impacting our services.
Yeah. Could you remind me of what the savings that you made this year? Was it 40, 47?
43 million.
43 million. What percentage of the savings from Encompass was that, roughly?
I wouldn't have that, but I can certainly get that to you, Danny. I wouldn't like to quote an exact figure.
No
I suppose
problem.
part of the issue is this thing I'm saying about the pharmacy. I wouldn't be able to say exactly what proportion of the overall pharmacy savings that we have directly linked to Encompass yet. But we know that the consumables and the printing have reduced by the hundreds of thousands.
Bear in mind it's all part year as well, Danny. We implemented in May. We only really in the autumn got into trying to take cost out of it. The first job was to make sure that everything was working.
The staff I mentioned, sorry, just coming back into my head, I didn't know the figure for it. The staff that I mentioned was about £1 million that we're taking out recurrently.
Okay. No, but it's certainly very encouraging, and it's good to hear something positive from the implementation of Encompass, and we're starting to see good results out of that. And obviously the pharmacy stuff you've mentioned as well is very encouraging. The thing that really struck me about what you've told us here today was the revalidation of the waiting lists and that 40% reduction. That's a shocking figure. And to my mind, that means that 40% of the people who were sick enough to be put on a waiting list and sick enough to need a procedure didn't get it in a timely way. And I think not knowing why they didn't get it, it seems very, very unended. We really should know how many of those people didn't get it because they became very acutely unwell and got emergency treatment and needed urgent care. How many of them became too frail for their procedures? How many of them went on to the private sector and paid huge amounts of money for a procedure that they've been waiting on for years? And how many sadly died on the waiting lists? And not knowing that, when we know that there's been such a reduction of 40%, I think is quite shocking. Is there any way you can retrieve that data so that you can become aware of that?
No, we'll have a look into that. I suppose the other group in that are the people, when we did the clinical validation, that the consultants decided those people didn't actually need the procedure they've been referred for. So there is a mix of other things in there that wouldn't necessarily mean that they needed it but they didn't get it. So we'll have a look to see what we can pull off in relation to that.
Certainly, I'd be very keen to see those. Now, we've asked quite a few times for that type of breakdown from the department and from trusts. I don't think we've ever received it, so I'll be very keen if you could provide the committee with that.
May well be we can have a look at how our Encompass system might help us doing it moving forward. But we'll get back to you.
Yeah, that's grand. Thank you, Chair.
So on that, Danny, I think because I was just checking with the clerk, so we actually have got a response in today, which will be in our pack next week in relation to that. Now I don't know what's in the response, but it may be nothing. But it's a very good point that we should, if that's not what we want, we should go back to the trust and try and access that information. Sorry, the department across all the trusts. Thanks, Danny. Alan.
Thanks, Chair. Look, I'll be really quick, conscious of time. Just on a similar theme to Linda, who made reference to the incidence of physical abuse. That was the standout for me here. Craigavon Hospital, those figures in that 4-year period have doubled. And it's not verbal abuse, it's physical abuse.
Yes. Yeah.
That's outrageous. And we were at the Northern Trust, I'm sure you're aware, there back a couple of weeks ago. And it was amazing to see something so small that can have such a big impact, those devices. And it just defies belief that these types of devices, which are having a great effect in one trust, cannot be rolled out to another trust. I think it's really important that that happens and happens pronto. Are you capturing the reasons that is driving some of these physical attacks? And could you maybe give us some detail of the nature of some of these physical attacks? Because we've heard in the past on here where staff have had busted and broken eye sockets. People have been knocked out. Is that the level of physical attack that you're experiencing?
No, fortunately that will be a very severe attack. Most of them are aggression, pushing, trying to swing a punch and not landing. It's that will be a really serious incident. But I mean, in terms of drivers, we know that you probably saw in our numbers, we've had a dramatic number of increase in the number of mental health referrals, 26% up in a year. Really striking. Our occupancy in the mental health unit bed occupancy has run at over 100%. We've been putting up extra beds. The recommendation is you should be averaging around about 85% occupancy. So that's been a particular issue within the mental health service that's caused a lot of problems. We also know that violence correlates with longer waits in ED. And of course, that's exactly what's been going on. People getting very frustrated and difficult. Inability to take them as well into areas where they can be isolated with staff as opposed to with other members of the public. So it becomes an extremely difficult working environment in ED. A third issue for us, which we are looking at right now, is as we've looked actually at our flow problems, it's clear that there's consistently a number of people, usually with dementia, but with very challenging behaviour in the wards, who aren't being very well cared for. We had actually 2 serious incidents in one night recently involving that group of patients. And what we've commissioned is a piece of work to look at do we create a specialist location and units to take that group of people away from acute wards and provide them with appropriate care, but protect others, staff and patients from their behaviour. So that's something we're looking at right now.
That's very helpful, Steve. Appreciate that. Thanks.
Okay. Sorry.
Well, I was going to make the point just before I bring you in that I mean, it's important that we highlight when things go wrong and probe and ask questions when we think they're needed. but it's important that we recognise the work. First of all, it's important to recognise that there's no excuse for violence against any healthcare staff, and that needs to be condemned. And also, we want to thank your staff for the work that they do and within our health service. I think it's important that we balance those views. Linda?
Quickly.
Just a very quick question, Chairman.
Okay.
Just it's really unacceptable, the figures that you've given us about assaults and staff and stuff. Have you any sense that alcohol or drug abuse has contributed to the increase on antisocial behaviour within public areas, or indeed assaults on your staff?
I mean, I'm not aware we've got any specific information, but it won't surprise you to know that alcohol and drug abuse rears its head in the emergency department and in the mental health service. I can't say more than that now. We could see if we could say anything more concrete.
Certainly, any legislation to maybe minimise alcohol abuse would be, I'm sure you would welcome
that. You're asking really a personal view. I'd have to see what legislation was proposed, I think is my answer.
Yep. Okay, thank you.
I think he was hinting at the minimum unit pricing of alcohol.
Oh, you're on the ball.
I'll not put words in his mouth. Linda?
I just wanted to make two very quick points. Number one is, I think for the issues within ED, it's very clear to be seen the capital is the problem, because everybody is on top of each other. It's not just the ED, it's everybody out in the foyer area. They're literally on top of each other. So that's a problem, and that's going to in itself create issues. You've said it yourself, there's nowhere to take people who are maybe just very vulnerable at that moment in time and just need a wee bit of space, and people with neurodiverse issues as well, being in the middle of that, it's absolute madness. I also think maybe make your case. The Minister has told us that he's looking at the potential for dementia-specific wards. So make your case, be the pilot project. Let's not have to be the South Eastern Health Trust for a change. Let's be the Southern Health Trust. No offence to the South Eastern Health Trust, but they get all these great pilots, and I feel a wee bit aggrieved that the Southern Trust doesn't. But I actually think, given the issues that you're having, maybe there is an argument or a case to be made around that specific issue, because I am extremely concerned by the high level of assault. I do think that there needs to be
another good reason for us to actively pursue it. Let's beat the South Eastern Trust.
But space is a big problem. Space is a big problem, and I think it does absolutely need to be addressed. So maybe we can make that case to the Minister.
This health committee supports all the trusts.
Can't blame me for being parochial. Well, you're the chair, you have to be.
Okay, I have no other members wanting to come in, so we'll get around to everybody. Really appreciate you coming and taking our questions. Thank you very much.
Thank you. Okay, thank you for your support.
Yes.
Okay, members. So I'll just give you a second, and then we'll move on. Okay, everybody, so we'll move on to item 9 on the agenda, SL1, which is the Firefighters Pension Scheme Amendment Regulations. So can I refer everybody to papers at tab 9, page 178 of the pack. So included Clerk's memo. The SL1 itself is at page 182. There's a proposed SR and an explanatory memorandum at 188 and 191 between those pages. So can I refer members, or remind everybody actually, that the SL1 is subject to the new process that we discussed a number of weeks ago and was introduced on the 5th of January. So members will not be asked to make a decision about the policy merit of this proposed statutory rule today. What we will do is, the purpose of the proposed rule is to update the member contribution structure in the Firefighters Pension Scheme. This will address a yield shortfall and will future-proof the contribution structure and ensure that it remains responsive to changes over time. So, statutory rule will be subject to negative resolution procedure. So I'm going to ask today that we note the SL1 and proposed statutory rule, and that these will be published on the Assembly website and social media as part of the call for evidence on the proposal. Also going to ask that we agree that SL1 will be scheduled for consideration at the meeting on the 5th of March, and asked if everybody's content that a briefing from officials isn't necessarily needed at this stage.
Agreed.
That's 3 things. Okay, thank you. Another SL1, it's item number 10. This is the Human Medicines Amendment Regulation. So, tab 10, page 194 of the main pack, and that includes a memo from the Clerk at page 195, the SL1 at page 197, the SI for the Human Medicines Amendment Regulations is at page 207, and the explanatory memorandum is at page 216. This instrument makes amendments to the Human Medicines Regulations 2012. The HMR's shortened version governs the arrangements across these islands for the licensing, manufacture, wholesale dealing and sale of medicine, supply of medicine for human use. The purpose of the proposed statutory instrument is to continue to support COVID-19 and influenza vaccine programs here in the north. So, can advise members, as this is relevant to the North and Britain, and it's an instrument that is subject to the highest level of Assembly control, which is a draft affirmative procedure. The committee is asked to agree to schedule a briefing from departmental officials on the proposed rule at the meeting on the 5th of March. Okay, so is everybody content that we note the SL1 and the proposed statutory rule? Note that these will be published on the Assembly website and social media as part of our call for evidence and views on the proposal. Ask that we agree the SL1 be scheduled for consideration at the meeting on 5th of March, and ask members if you are content that the briefing from officials is scheduled for the 5th of March.
Content.
Okay, there's a lot of reading to get to that. Okay. Item number 11, written briefing from the Department on the progress on implementation review of emergency general surgery at South West Acute Hospital. Can I refer members to papers at tab 11, page 227 of main pack, including a written briefing from the Department, page 228 of the main pack. Also, there's a response from SWAH regarding the Western Health and Social Care Trust, and also there's statistics from SWAH on population data. Just if members have any comments to make on it. Are members content that we forward the briefing from the department to SOAS? Yes. I mean, this is an issue that I imagine we will raise, some of us, when the Minister comes, so I don't think we're going to get much further forward until we hear the Minister's views on it. So everybody's content with that? Correspondence. Can I refer members to correspondence in the main pack from page 291, and that all includes a correspondence index at page 293. Can I refer members to correspondence at tab 12.2, page 296, and it's regarding palliative end-of-life care scoping exercise. So just wondering if members have any comments on that. So it's like not a lot has happened from it. I mean, we're still awaiting the response from the Minister in relation to her inquiry. So, you know, all this is going. Danny, are you looking to come in on that or something else?
Yeah, just briefly. I think it was this time last year that they announced that they were doing this and it was going to start. Mm-hmm. And in that time, we produced an inquiry and a report. So it just shows you how kind of slowly things are moving.
No, absolutely. And we will keep the pressure on the Minister in relation to the our recommendations. I suspect that some of it, because it does have budgetary constraints, will be maybe not possible to get until he gets confirmation in the budget, but we'll wait and see that. Okay, members, also at tab 12.16, page 30 from the Department regarding the publication of the Social Care Fair Work Forum justification document for the real living wage. I mean, my comment is, we're talking about this every week at this meeting. It is ridiculous. It's clear that real living wage needs to be given to those staff immediately. I mean, that's further justification, but I'm certainly at this point fed up saying that. What we need to see is actually it happening in reality.
Chair, I just think, I mean, I am obviously supportive of the introduction of the real living wage. These are people who deal with our nearest and dearest and work with them every single day. And the juxtaposition of that is the agreement of a new pay scale and a 6.5% increase for senior executives and trust chief executives, up to the actual almost $250,000 per year.
Yeah.
Huge money compared to the real living wage.
Yep.
I think that that's significant.
No, absolutely. I mean, I totally agree. And I mean, I do think, and in fairness to the Minister, he has said it's, and the Permanent Secretary reaffirmed that last week, that pay will be dealt with as a first issue in his budget. So we will hold them to that. I mean, it's important that our staff, regardless of what work they're doing within the health service, are appropriately paid. We shouldn't be having a conversation about the real living minimum wage. Staff should be getting paid much more than that, in my view. Anyway, refer just members to correspondence also, tab 12.2, it's page 574 from the Business Office regarding access to general practice here in the north. I don't know if anybody has any comments on that.
I just make
Yep.
So I have been getting representation really from practices that are run by community interest companies, practices that, you know, have had huge difficulty and where contract has been handed back. And I was just wondering if we could maybe just even something in writing from the Royal College of GPs around that particular issue, so that we know, is this just something that I've experienced as a local issue, or is this a wider issue, and what has to be done about it?
Okay, I think that's...
Because I'm meeting a range of practices tomorrow.
Okay. On the similar issue in terms of GPs, page 740 with from the BMA regarding an update on the GPs committee negotiations with the department. We want to see that issue resolved. It's vitally important that it is resolved. I see today there's the GPs in Scotland. I think I've got a 10% pay increase. Don't want to be misquoting that. I just read it off Twitter. I was going, but I've seen some of our GPs commenting on that. So I certainly hope we know the importance general practice is within our health service, and we need to get it issue resolved. I just want to raise also the correspondence, which my computer shut down there a second or two ago, so I haven't got it. 1232, thank you. Page 761. So, I mean, this letter came to myself from David O'Prey, and I can mention his name because he's given me permission, and he's actually been to the media himself, in relation to a blood transfusion that was given to his partner, who died a month after that. So it's subject to a level 2 serious impact assessment, but I mean, on the face of it, it seems concerning, and in our pack we're linking it to the discussion with the SIS coming up. Just what dates, because I think my thing's not, so it just it was sent to me and I forwarded it on for the committee, so it's just something that's concerning in terms of making sure these types of investigations are resolved quickly and satisfactorily and looked at appropriately. Just while the clerk's looking at that, members, anything else? Sorry, Linda.
2 quick points on the correspondence. The first one is 12.13, which is the letter response from the Minister to our letter about the missing smear tests. And based on the response that we got today, I mean, I don't think this is a Southern Trust issue. This is an issue that could happen in any of the trusts, given that Belfast is doing those for all trust areas. So I think we write back to the Minister. His answer tells us nothing. Write back to him and ask him, can we get a timeline as to when they might tell us how they're going to address this to make sure that it never happens again, and I mean, I think the answer we got today is that we don't know what happened, and we've kind of accepted now we're not going to know what happened. But just, I like that from the department. I'd like a clear answer from them, so I'd like to go back to them with those specific points. Do you know where they went or how they went missing? And whether you know that or not, what are you now putting in place in a time frame for when it will be put in place to make sure this never happens in any trust area? Because the Southern Trust are doing their piece in terms of following up those ladies who went missing, and that was all done very quickly, thankfully, but there's 14 women who haven't come back, and it's not pleasant. The other one is just on 12.31 on the ADHD, and I know we've said ask for written briefing from the department. We kind of know what the written briefing is going to say. We got it last week during our debate, so maybe if we just ask for a written briefing, can they include in that briefing any plans that they have, notwithstanding financial constraints, but should, is it a priority at all? Is it in their line of sight to provide a regional diagnosis service for adults with ADHD?
I met the minister at the event, I think was it yesterday or two, I can't even mind, every day but he did say that it was coming. He said in the debate the needs assessment was coming shortly. I thought he said it was going to be announced today, but maybe it's not.
So if it, just put it in the case, but my final point is just on the one not specific to the case you just raised, but you said, hopefully this will be dealt with in a timely manner. I think we can guarantee it won't be. In terms of any resolution, getting to the bottom of it, and then any kind of, if it goes down the legal route, I don't know whether it will or not, but I think in general I would like to get an understanding. We need to see some leadership. This is something we've dealt with in the policing board over the last number of years, around legal cases being taken against PSNI. And whenever they actually get to the end of it, after many, many, many years of families sitting, waiting, and people dying and everything else, that the legal costs for both sides ends up costing in the multiples more than the compensation that's paid out to victims. And I think we can already see that's happening in our health service. It's anecdotal, but I'd like some information from the department rather than the individual trusts about what is the length of time cases are going on. I'm dealing with one that I actually took on from Liz whenever she was on the committee, of a child who was injured at birth. The child is now 13 years old. Mm-hmm. How old is he going to be before he gets any help in his family? And he has very, very, very significant needs. But there's been no resolution because there's just this constant of not accepting responsibility for when things go wrong, and that just adds to people's hurt. So we need leadership on it. That leadership needs to come from the top, and PSNI have made some moves in this regard, and it is helping, and it is helping families to accept that they're trying to do the right thing as well. So maybe the department could benefit from that in terms of public confidence, as well as just people actually getting what they need to live and survive. So if we can write to them and ask, is there, I don't know.
Say when they're coming in that briefing?
The SAI framework we were meant to get briefed on that a number of times, and it's been pushed back and pushed back. So the latest we have is we have requested a written briefing updating us. So we can maybe highlight that one to the department as a example of. But we're still waiting on a confirmation date of when that framework is going to be ready to be for the committee to be briefed.
Can we ask them, do they have overall figures of how many cases are ongoing, what length of time they're ongoing, and if there is any kind of information around the cost, because we can look at it in terms of PSNI, what it is. We have exact details of what cases cost, what the breakdown of the figures is, how much money is actually paid to legals, and then how much is paid in compensation. I'm sure that the department have to have that information.
Yep, Danny.
Thank you, Chair. Chair, just to highlight, you were saying about the ADHD, the needs assessment report that was published today. It's on the Department of Health website. It's 99 pages long, and there are 19 recommendations. it's certainly worth a read, and maybe we could. I think we have a briefing scheduled on it soon as well. But just to let members know that is on there on the Department of Health website.
That's good, because I met the Minister and he did tell me it was going to be published today.
Could I highlight two things? Just the change in places in hospitals at 12.9. That's great to see. I've had families contact me about the lack of change in places and having to change people on toilet floors, which is absolutely inappropriate. But good to see, there is some progress there. And the other one is, I think it's PSNI, but it's the Pharmaceutical Society of Northern Ireland one. And I think it's 12.26, Pharmaceutical Society of Northern Ireland, a change to regulations, and we've just to send that. Could I ask if that's been sent to Community Pharmacy Northern Ireland just for comment?
Okay, yep. No issue with that.
Thank you.
Thanks, Danny. Nobody else? Anything? Happy to agree the correspondence action table, page 293. Happy? Okay, forward work programme, draft forward work programme, page 768. Everybody content?
Yeah.
AOB, none. Date, time, place of next meeting. Next committee meeting, room 29, Thursday, 19th February, 2 p.m. Adjourn the meeting.